Hello, sir.
Okay, Sandesh, can you hear me?
Yes, sir, we can hear you.
But there is some echo.
Sir, from our side, we'll be stopping the audio. Only during the question we'll resume it.
And I'll be sharing the presentation and check whether it is possible. Sandesh, can you see the presentation?
Yes, sir. We can.
What about the audio?
Audio is clear.
Okay, thank you.
I'll introduce the chairperson and then we'll start.
Okay.
Yes.
Hello. Sir, can you hear me? Hello. Sir, can you hear me? Good morning, esteemed guests, distinguished colleagues, and all of you passionate about the intriguing intersection of law and psychiatry. It is indeed a pleasure to see so many bright minds gathered here today for the national level CME on law and psychiatry, organized by the AJ Institute of Medical Sciences and Research Center, Mangalore, Karnataka, in collaboration with Mangalore Psychiatry Society. My name is Dr. Sandesh, third year postgraduate from AJ, and I have the privilege of being a master of the ceremony, a role I take on while expertly navigating the intricate rules of this fascinating field. We have a captivating and thought-provoking session ahead, featuring the esteemed Dr. Suresh Badamat, who will enlighten us with his insights and expertise. To guide us through this session, we are fortunate to have Dr. Poonam M. as our chairperson. I request Dr. Poonam to join us on the stage. Dr. Poonam completed her MBBS from KMC Mangalore and has pursued an MD from St. John's Medical College in Bangalore. She began her teaching career as an assistant professor at Vaidehi Medical College in Bangalore before advancing to the roles of associate and professor and head at KVG Medical College, Sulya. With her vast expertise and sharp insights, Dr. Poonam will now take on the stage and introduce our esteemed speaker for this session, Dr. Suresh Badamat.
Very good morning to all of you gathered here. And without much delay, I think I will introduce the speaker. And it's my honor to introduce Dr. Suresh Badamat, an esteemed person with his qualifications. So Dr. Suresh Badamat, along with his MBBS, MD and DNB, has the following degrees from National Law School of Bangalore. He has done his PGDMLE, that is Postgraduate Diploma in Medical Ethics and Law, and a Postgraduate Diploma in Human Rights and Law, that is PGDHRL, from National Law School of India, University, Bangalore. He also did a PhD in Law and National Law School of India, University. He is Professor of Psychiatry, Head of Forensic Psychiatry Unit, Head of Telemedicine Center, and Head of Unit 5 General Psychiatry, Office in charge of NIMHANS Digital Academy, NIMHANS Bangalore. He has 405 publications in national and international journals, including editor of 13 books. He has won many awards. Notable one is Sir C.V. Raman Young Scientist Award and Professor Raghuram Young Teacher Award. He is the chairman for the National Task Force on Mental Health and Well-being of Medical Students 2024, established by the NMC New Delhi. He is a TEDx talk speaker. He has also played an instrumental role in drafting Mental Health Care Act 2017 rules for the Health Minister. So here we have a lawyer cum psychiatrist who will be addressing today. Over to you, sir.
Thank you for the introduction, ma'am. With your permission, can I start?
Yes, sure, sir, sure.
Okay. So, welcome you all for this today's symposium. So, today I'll be discussing about medical negligence. These are my credentials. I'm teaching currently, apart from being in NIMHANS, I'm teaching at National Law School, Gujarat, and also at the National Law School, Aurangabad, as a guest faculty. So this is my YouTube channel where you can find the today's presentation available. So in today's next 30 or 40 minutes, we will be discussing about these important 6 concepts which are applicable in medical negligence. So first, let's understand about the Bolam test. So with regard to medical negligence, the first thing which occurred with regard to medical negligence, which came from psychiatry. This was somewhere around 1955 or 56. This is a landmark British case. Till then, there was no any major, if we call a landmark decision which gave a yardstick to assess medical negligence. So in this Bolam, he is a Mr. Bolam who is a voluntary patient at the Friary Hospital. He is suffering from recurrent depression. He had multiple depression earlier. And in the current severe depression, he was told that they will give ECT. That is electroconvulsive therapy. Please understand, it is in 1957. And then they will go ahead with the unmodified ECT. Unmodified ECT is basically electroconvulsive therapy without anesthesia and muscle relaxant. Invariably, 2 or 3 people will hold their hands, and then the electroconvulsive therapy will be given. That is a mild electrical current, or electrical current is passed through the cranium. Invariably, the understanding is if there is a seizure, the depression or psychosis will remit. That means seizure and mental illness do not coexist. That was the thinking at that time. Hence, some or the other way we have to induce seizure. The one of the best way was passing electrical current. So in the first ECT, nothing happened. Second ECT, he did well. Third ECT, he improved. But unfortunately, he suffered fracture. Once he suffered fracture, he went to the court telling that I went there for treatment. Unfortunately, the doctors and the hospital gave me this fracture. And he has appealed to the court telling that the doctors should be punished and I should be compensated. At that time, in 1957, there was no yardstick to assess whether the doctors were negligent or not. So there, the Judge McNair was the judge who was there in UK, and he was stunned what should do. Then he called the experts. The experts, when he asked, is this the case where the doctor should be punished and the hospital should be punished? The experts were divided. 50% of them said that we give ECT with anesthesia, muscle relaxant, we restrain and warn the patient. The other 50% said, no, we don't give anesthesia and muscle relaxant. It is dangerous to patient because in 1957 anesthesia was developing. So they said, if we give anesthesia, it is more dangerous than the ECT itself. So the house was divided. 50% said we will give and 50% said we don't give anesthesia or muscle relaxant. So further the Judge McNair was again confused what to do. But here he came up with a landmark decision which is applicable across the world, not in UK, not in India, across the world it is applicable. That is Bolam's test. in 1957. What was Judge McNair said at that time? A doctor is not guilty of negligence if he has acted in accordance with the practice accepted as proper by a responsible body of medical men skilled in that particular art. That means during that period in 1957, there were two practices. One practice is to give ECT with anesthesia. Another was without anesthesia. Both are acceptable by the fraternity. Hence, the Judge McNair said the doctors and the hospital is not responsible. They are not medically negligent. And he also said that if a doctor reaches the standard of a responsible body of medical opinion, he is not negligent. That means it is more of if we are able to follow what our peers or our professional group follows, we are not negligent. This was UK's decision in 1957. It is now accepted even in India. Jacob Matthew case, which is a landmark case, which is given by the Supreme Court of India, Suresh Gupta versus NCT of Delhi. In both the cases, the Bolam test has been referred. And even in 2024, in couple of cases, the Apex Court has discussed about Bolam test. That means it is applicable even in India. So, in nutshell, failure to use such care as a reasonable, prudent and careful person would use under similar circumstances invites medical negligence case. That means if you do not follow the professional standard, for example, in Indian Psychiatric Society, we devise something called as clinical practice guideline. We need to follow that. Now the question arises, which guideline? Should I follow Indian guideline or American guideline or NHS guideline? In simple words, we are in India. When you are in India, you need to follow Indian law, similarly Indian guidelines. So that you need to understand. But however, the Bolam test has its own criticism. The criticism is the society, the lawyers and many other professionals say that their doctors will never give opinion against their own fraternity. So this is the biggest critique, telling that the doctors will never go, but unfortunately we do not require enemies. The enemies are sitting next to us. Invariably, if you make a small mistake, our own peers or even our students will say you are wrong, and they do not hesitate to come even to the Supreme Court and say this doctor is wrong. Of course, it's a professional jealousy, but this critique telling that doctors do not give opinion against the doctor may not hold good, but unfortunately, this criticism continues to exist. Now let's move on to the summarizing the Bolam test. Simple is a failure to match up the required standard of care. So we need to have a standard care. The court does not want highest standard care the way it is given in AIMS Delhi, or else the poorest standard given by a layman or maybe a faith healer. But the test used is peer review. Just like a publication, when we do publication, the peer review is done. Similarly, in the court of law, it is the peers, that is basically the experts, will give opinion. So this is about the Bolam test. But at the same time, there is something called as Bolito test also came in. Let's understand about Bolito test. This is again in 1997. So that was in 57. And after 40 years, it has been reviewed. So that is, again, both starts with Bola, that is BOL. So here also BOL, Bolam, Bolito. So both are similar in nature, and because of the names which are used in UK. So here is a Patrick Bolito, a 2-year-old boy who was suffering from severe cough, and he was admitted in St. Bartholomew's Hospital. He was admitted under Dr. Horn and Dr. Roger, and they were looking after him. He was admitted in ICU because he used to have severe cough, and whenever he had cough, he used to go to breathlessness. And in one instance, when he had severe cough, he went into apnea and also cyanosis. The nurse immediately called the Dr. Horn, telling that the Patrick Bolito, the young child, is having this problem. Unfortunately, Dr. Horn and Rogers were also on duty. As you know, if the doctor is on duty, he is on duty both in emergency and also across the hospital. By the time they came, the child recovered. This happened second time, and again the doctor did not come. Third time, the second time the nurse called and said the child recovered. The third time when the child again went into a severe cough, the child, again the nurse called for the Dr. Roger, but unfortunately they don't come because they are busy in the casualty. The child suffers a brain damage, and later after 2 weeks the child dies. Now, the parents go to the court telling that the doctors did not take care of our child. Now again the court, as per Bolam's test, called the experts. So the experts said, if we had gone to ICU, 50% of the experts said, we will go there, we will give oxygen and symptomatic treatment. Another 50% said, no, we will do intubation. But the people who said we will give symptomatic treatment, if you try to intubate, as you introduce already the child is coughing, if you try to intubate and the larynx is already irritated or trachea is already under irritation or inflammation, it will go into severe spasm, the child will die. So again the experts were divided. Now if you apply Bolam test, since the doctors would have followed either one of them, either it is symptomatic treatment which the nurse was giving, that is giving oxygen and giving cough suppressant, or else come and do intubation. So whether the doctors were negligent or not was the question raised by the court in this case. But the court went otherwise. It says Bolam test gets nullified when a body of experts' opinion cannot withstand the logical support. What was here? Both the experts group said that if we had gone to ICU, unfortunately the doctors did not go to ICU to examine the child. So here the Bolito test said that Bolam test becomes nullified because the doctors did not go to ICU. You can't apply Bolam's test here. Because if the doctor would have gone, he would have chosen either one of them. So the Bolito test clearly says if you want to use Bolam test, the Bolam test should be logically explainable to the court of law. If you are unable to apply the logical explanation why I am using this Bolam test, the Bolam test will be squashed. That means just because the peer review said if the doctors would have gone there, they would have done A or B, and A is already been done because nurse is giving the oxygen and the treatment. Invariably, the judge said that the patient was admitted in ICU and 3 episodes occurred. In all the 3 episodes, the doctor did not attend the child. Hence, it went against the hospital. So that is how the Bolito test came into picture. What about the Bolito test in India? The Bolito test in India, fortunately, it has been considered only in one case, but who knows, anytime they can wake up and say, although we may use Bolam test, but Bolito test has to be there along with Bolam, telling that if you give an opinion, it should be logically explained to the court and the court has to accept it. So we have discussed about Bolam, Bolito test. Now let's talk about, considering Bolam and Bolito, should we follow clinical practice guideline? With regard to clinical practice guideline, there was a landmark decision which was given by the Supreme Court. This is Maharaja Agrasen Hospital versus Master Rishabh Sharma. In this case, a young lady who is 32 weeks pregnant, having placenta previa, goes to Sharma Medical Center because she has a premature rupture of membranes. At the 32 weeks, Dr. Rama Sharma, who is a gynecologist, will do LSCS. Unfortunately, the child born was premature and the weight of the baby was 1.5 kg and it was critical. Since Dr. Rama Sharma did not have neonatal ICU, she referred the child to the Maharaja Agrasen Hospital. The child was kept in the ICU again, in the incubator. Oxygen was given, surfactant injection was given, and after 30 days, the child was discharged, the mother was fine, child was fine. But unfortunately, after 6 months, the mother noticed the child is not responding to the stimuli or eye stimuli, basically for the light. She goes to the doctor, to various other ophthalmologists. They said that the child has developed stage 4 retinopathy of prematurity. That is ROP in both the eyes, and there is total retinal detachment. Mother becomes very angry and goes to Rama Sharma and asks for medical records and see, my child has become blind. She says, I was in charge of you, not about the child. It is Maharaja Agrasena Hospital who has dealt with your child. You go to them. She doesn't get the medical records. She had to go to Delhi Medical Council. Delhi Medical Council has to order the medical records to be given. Finally, the records were given. In the record, nowhere fundal examination was mentioned. And the copy was given to the mother. Later, it was presented in the court of law, and clearly it was no ROP was mentioned, and later during the trial they found that ROP was introduced later, that telling that we have examined the fundus, and the Supreme Court found this, telling that they have tampered with the records and they have not done the funda examination. And the government of India had clearly said earlier that all premature babies needs to undergo fundal examination. Sorry. That means there is already a guidelines given by the government of India, Ophthalmologist Association of India, telling that in all premature babies, fundal examination is a must immediately after the childbirth, and after 1 month, 3 months, 6 months, and follow-up has to be done. And if there is any retinal detachment, early signs are there, it can be halted by giving laser therapy. So in this case, the Supreme Court clearly said that the hospital is negligent. So 1.5 crore rupees compensation was given for this. That means you need to follow clinical practice guideline. And the Supreme Court was very clear. If a guideline have been produced by a respectable body and has been accepted by that professional body, and a professional is not following, he needs to have a strong reason why he is not following the guidelines. That means if there is a guidelines formed by either Indian Psychiatric Society or maybe South Zone or even Karnataka IPS has come up with a guideline, and if you are not following that guideline, you need to have a strong logical reason why you are not following. Other better you follow the guideline. The similar case, Krishna Kumari versus State of Tamil Nadu, 2009 judgment also follows the same, the ROP case, which the case was against the government doctors. The Supreme Court clearly said that 50 lakhs has to be paid by one government doctor and another government doctor. Remaining has to be paid by the state of Tamil Nadu. So, in both the case, the Supreme Court not only told that the hospital is payable, but also to the doctors, the amount was fixed. To summarize, we need to follow clinical practice guidelines. Now moving to understanding the final part. Till now I was talking about Bolam test, Bolito test and clinical practice guideline. Now we will talk about the medical negligence proper. Without all the three, Bolam, Bolito and clinical practice guideline, understanding medical negligence becomes difficult. Because these are the bricks of the understanding of medical negligence. Medical negligence means it has three important components. There should be a duty of care. The doctor owes duty to the patient by the virtue of seeing the patient, examining the patient, giving prescription. That means you owe the duty to the patient. If there is a duty and there is a breach in that duty, what is that breach? It can be act of omission or act of commission. If either of this occurs, then and it causes damage to the patient, then it will be considered as medical negligence. So three important criteria. One is there should be a duty of care. There should be breach of duty, either act of omission or commission. And because of the breach, there should be an harm to the patient, and that harm should be compensated. That is medical negligence. So duty of care, how does it established in the court of law? The patient will invariably produce hospital receipts, bills, prescription that establishes duty of care. But invariably the duty of care, you can say I will not see the patient if it is not in emergency. But in emergency, you do not have any choice, you have to examine the patient. What is this breach of duty? Act of commission. Doing something which no doctors does it. That is, leaving scissors inside the abdomen. Act of omission. Not doing something which every reasonable doctor will do. That is, doing penicillin test before giving the injection. That is, skin allergic test is done. So the act of commission, omission, these are the example. With regard to psychiatry, a patient who is suicidal, invariably we admit. If you don't admit, invariably it will be considered as act of omission unless you have a strong reason that the patient is manipulating or trying to threat. If there is a serious threat, you need to admit the patient. If you don't admit, invariably the act of omission will be considered. That is an example I am giving you. So if there is a breach of duty, and that should result in the damage or pain to the patient. There is a breach, but there is no damage, means there is no compensation. Imagine if you have diagnosed a patient of schizophrenia with bipolar, and you have given valproate medicine. Later, Dr. Ravish Tunga will say, no, it is bipolar disorder, how can you call it as schizophrenia? But you have given valproate, no side effects has occurred. That means there is no damage. There is a wrong diagnosis. That does not amount to negligence. Negligence should have damages. To be very clear, precise. So if there is no damage, no compensation. So duty of care, breach of duty, because of breach there should be a damage. So these all three things should be there. But invariably, in the recent case which has occurred in UK, this duty of care, not only providing care, but also with regard to advice and counseling has come into picture. Let's discuss about this case. This is Montgomery versus Lancashire, 2015. This is a very interesting case. Invariably, we Indians being the loyal to Britishers, so we invariably import those cases. It's not far, we will be importing this case also to punish our doctors. So let's understand about Montgomery versus Lancashire case. In this case, Miss Montgomery, she is a 35-year-old lady who is insulin dependent, diabetes is there, and she is with late pregnancy. Late means she is the primary now at the age of 35, but she is short statured, somewhere around 5'6". She has become pregnant first time, and she goes to the doctor. The doctor is very conservative and he says everything will be fine, don't worry. She goes to antenatal care religiously with ritualistic behavior, that she goes every antenatal care. No antenatal care was missed. The doctor decided to go with the normal vaginal delivery. He did not discuss anything about cesarean, or she being short stature and also having insulin dependent diabetes. He did not talk about the child may be huge. Unfortunately, when the child was being tried for normal vaginal delivery, the child went into shoulder dystocia and there was a cord prolapse. What happens here? This is how it happens. Shoulder dystocia, here if the child is huge and the short stature is there, the shoulder gets stuck during vaginal delivery and invariably the cord prolapse occurs and the child had cerebral palsy. In this case, the mother became very unhappy, and later they did the cesarean and the mother became very unhappy, telling that my child has become cerebral palsy has developed. The doctor did not discuss, did not tell me about, even offer about cesarean section. It went to the court. In the court, The doctor argued, no, I'm a very good ethical doctor, gynecologist. I don't do cesarean. I usually try for vaginal delivery. Again, the Bolam test was called. In this case, in the Bolam test case was applied, most of the experts said that considering the risk factors for obstructed labor, short statured, primary, and also insulin diabetes, insulin dependent diabetes, ultrasound also clearly indicated about the birth of the child, and the doctor did not take any precautions. He have went ahead, but he used in defense telling that, no, I don't do indiscriminate cesarean section. In this case, the Supreme Court of UK gave a landmark decision. And it clearly said that if you don't discuss the side effects with the patient, it will be amounted as a negligence. And it gave a landmark decision telling that it is the duty of the doctor to discuss side effects. And it is the rights of the patient to know the side effects. That means it is no more, I will tell only one or two side effects. It is your duty to tell, and it is the rights of the patient to know. And here a huge amount of compensation was paid. So in similar cases, if you look at in Indian scenario, civil negligence case, Balaram Prasad versus Kunal Shah, that is AMRI versus Kunal Shah, a landmark decision given by our own Supreme Court judge from Karnataka. But he was the Supreme Court judge, and the 12 crore rupees compensation was given in this case. I will not go into this case in detail. It is available online. In this case, for various reasons, they gave a compensation of 11 crore. So I have published this, available on the Annals of Indian Academy of Neurology 2016. We have published this. You can go through why the compensation was given huge, whether is it right or wrong. It can be known because of the shortage of time. So how the compensation was calculated? Compensation was calculated based on loss of income, if the person who is alive, or he has damaged or he has developed disability. What is the medical cost of which occurred during the past, present and future? The cost for pain and suffering, litigation cost, if there is inflation, if there is interest. Imagine the case was instituted somewhere around in 93 or 94, and the decision was given in 2014, 2012 or 13. So till then, whatever the compensation was given, for that the interest has to be given by the doctor. And unfortunately, what happens in India, the judgment comes only after 2 or 3 decades. That means if the patient has asked for 1 crore, imagine after 3 decades, you have to give not just the 1 crore, with interest you have to give, with punitive compensation and loss of consortium. On that basis it is given. So this is how the calculation is done. I will not go into this. You can find the publication. So summarizing, the medical negligence, every doctor has a duty to act with a reasonable degree of care. Reasonable means not the care which is given at Nimans, or a care given at the lowest faith healer. It has to be reasonable. What does it reasonable means? If there is a group of doctors in Mangalore, they are practicing, how the ECT is given, so all the doctors should follow the same. And if you don't follow, it will be considered as negligence. So summarizing, the practitioner should bring his reasonable degree of knowledge, reasonable degree of skill, not the highest level or the lowest level. It is the reasonable degree. In simple, negligence may result not only in civil liability, but also criminal liability. What does it mean? Criminal liability means punishment. Civil liability means consumer court. Now, with the next 5 to 10 minutes, I'll talk about the criminal negligence cases. The civil negligence is going to medical council, civil court, consumer court, maybe private, Karnataka Private Establishment Act is there, Human Rights Commission, Women's Commission, Child Rights Commission. With regard to criminal negligence, earlier Indian Penal Code was 304A, and our politicians have said at that time when the Bharatiya Nyaya Samhita was drafted, they said doctors will not be considered. But as for today, as for Bharatiya Nyaya Samhita, 304A of IPC is equivalent to 106. What does 106 says? Causing death by negligence. It says whoever causes death of a person by the virtue of doing a rash and negligent act, not amounting to culpable homicide, shall be imprisoned either for a description of a term which may extend to 5 years and also be liable to be fined. If such act is done by a registered medical practitioner, the punishment is 2 years and fine. Earlier it was either 2 years or fine or both. But at present, it is 2 years and fine. So that means we have not been removed from the rash and negligent act causing the death of the patient. So if it is proved in the court of law, it is gross negligence, not negligence, gross negligence. Then a criminal charges can be given. So in this case, there are two landmarks decision has come from the Supreme Court. One is Suresh Gupta versus Government of NCT, another one is Jacob Matthew. Invariably, most of us discuss about Jacob Matthew versus State of Punjab. This landmark decision I'll be just going through because every doctor should know about this. Here in this, it says it is not the requirement of just a medical negligence. The medical negligence should be gross. Gross to that level, no doctor will do that. If the no doctor is doing and the doctor has done, then it is a gross negligence. Let's discuss this. The Jacob Matthew versus NCT of, State of Punjab. In this case, what happens is, during 92 or 93, Jacob Matthew is a resident, junior resident, second year PG of surgery. He was studying in CMC, Ludhiana, as a surgery PG, and he finished his OT in the evening. And he was walking towards his hostel around 6 o'clock. 6 in the evening, and in the 6 in the evening when he's walking through the wards, there was a commotion in one of the special ward. So one of the nurse came running towards Jacob Matthew and said, Dr. G, please come. There is a patient who is gasping. So Jacob Matthew, being a doctor and there is an emergency case, he accompanied the nurse. Although it does not belongs to him, or to his unit, or to his consultant. He asked what is the case. Then the nurse clearly said, here is an elderly man who is from a rich family with political background. One of his son is a IPS officer, and this elderly man is in terminal cancer. The doctor had explained to the family that he is in deathbed, nothing can be done. But the family insisted that to be given hospice care in the hospital. Because of the political pressure and also the pressure from the police, they had kept the patient. Because the patient is in deathbed, they can't take care in the house. So the doctor went there, and then they said, the patient is gasping. He said, please bring the oxygen cylinder. Since the patient was in a special ward, they had to get the oxygen cylinder from the basement. So they brought the oxygen cylinder, connected the oxygen to the patient. Unfortunately, the cylinder was empty. Then again they had to go get the another cylinder. By that time the patient died. The whole commotion was seen by the family members. They gave a phone call to one of the son who was an IPS officer. He came with the police. And the Jacob Matthew was nothing to do with the patient. He is a doctor there, but it doesn't belong to him. He is from a surgery department, and the patient belonged to the medical oncology. And he was made to sit there for almost till 4 a.m. in the morning, and he was allowed to go. And he thought everything is settled. By 1 month down the line, he comes to know there has been an arrest warrant against him for rash and negligent act causing a death of an elderly man. Imagine he is in the second year trying to finish his PG thesis, and he comes to know there is a arrest warrant. He has to abscond, get the anticipatory bail, and the case goes on and on and on, and nobody attends the case. Nothing is done at the district court or in the high court. He becomes very frustrated. He writes to the Supreme Court. And the Supreme Court took this case. And then they heard the case telling that why it has happened. And then they clearly said the doctor is not negligent in this case and he has nothing to do with this case. And already that person was in the deathbed. The oxygen cylinder maintaining is not the doctor's duty. And the doctor is not responsible for the death of this patient. And they said, whenever you make a criminal negligence case, it has to be very gross. No doctor on the earth will do that. That means no doctor on the earth will keep an empty cylinder and he will give the empty cylinder to the patient, oxygen. And it said it is nowhere gross negligent, and it gave a guideline. Don't arrest the doctor at the whims and fancy. This will cause a defensive practice, and no doctor will treat any patient who is serious. Hence, it clearly said, gross negligence means no doctor on the earth will do that similar act. That should be that gross. And it clearly said, whenever there is a complaint against a doctor about a criminal negligence and FIR has to be done, once the family members give a complaint, he will not take the FIR. He will go to the doctor, take all the medical records, take the dead body, and the dead body will be submitted for post-mortem. Medical records will be sent to an independent expert opinion. They will go through the expert opinion. They will go through the medical records. And that medical record, looking into that, whether the doctor was negligent or not, they will give an opinion. After that opinion telling that yes, the doctor is negligent, then only they can file an FIR. Till there, you cannot file an FIR. This is the Supreme Court's judgment at this point of time. It is applicable even under Bharatiya Nyaya Samhita. So, if any doctors comes to arrest you for rash and negligent, either a death of a patient or a grievous injury, ask them whether they have taken a parallel opinion. If there is no parallel opinion, they cannot file an FIR. Tamil Nadu has given orders even from the police, IG, telling that no doctors will be arrested without a parallel opinion. And the parallel opinion includes post-mortem report. But invariably, many of the police do not know about this law, and also the police do not know. So with this, I'll be concluding my discussion, telling that for a medical negligence case, it can be civil case, consumer court, or maybe in the medical council, criminal case in the court of law. Please remember about Jacob Matthew versus State of Punjab. It is available online, and I have made a YouTube video on that. Please know your rights. Invariably, around 2.5 years back, we lost our colleague who, when there was a FIR made, she hanged herself, a gynecologist. That should not happen. If she knew her rights, she would have not done that, because that case was completely false and they have not taken any parallel opinion. That case would have been squashed by the Supreme Court. Without knowing the rights, whenever there is a negligent case, our doctors go into depression or they attempt suicide. That should not happen. So please know your rights. Thank you. Over to the chairperson.
Thank you, Dr. Suresh, for the enlightening talk. So he has discussed about medical negligence and law. So as far as we are concerned, we are also dealing with law and medical negligence every day, because we are prescribing drugs which are high voltage with very high side effects. So please make sure that you follow the rules and regulation. Make sure that you inform the patients about what side effects they will anticipate, or basically a little bit of knowledge, a little bit of conscience, and a good rapport with patients can avoid you from getting into trouble. So, if there are any questions, sir is ready to take it. Any questions from the Dr. Ganesh wants to ask?
Very good presentation, Dr. Badamat. I hope it is audible to speaker. My question is, if a person develops tardive dyskinesia after giving haloperidol, it is very, very rare side effect, and whether doctor is liable to be punished in this case, if it is proved that he has not told about tardive dyskinesia to the patient.
Dr. Ganesh, I could not hear your voice.
He could
I am
not
unable
hear
to get the audio. If somebody is able to repeat the question, I'll be able to respond.
Yeah. Can I repeat? Hello? Is it audible? Suresh?
No, I think he just sent a message saying it's not audible. Sandesh, just see. Can you type that question there?
I'm sorry,
Can you
I'm
hear
unable to
me,
hear the
sir? Dr.
audio.
Suresh, can you hear me? Can you hear me? I don't.
I'll give, thank you, Dr. Ganesh Prasad. So the question is like this, the Dr. Ganesh has said that if the patient develops tardive dyskinesia, so there was a case actually, even it came from Karnataka only, one of our well-known psychiatrists, I will not name them, he gave haloperidol, same, and the patient developed severe dorsal dystonia. And unfortunately, the patient was a minister's nephew. It was a big case actually, but there was a threat going on between the politician and the well-known psychiatrist, and somehow they settled out of court. We told them not to do that, but invariably they settled. So now coming to the point, if currently the Montgomery versus Lancashire case is not imported till now in India, if it is imported, the doctor will be held responsible. While if you look at the latest literature with regard to tardive dyskinesia, it is around 10 to 15%. That is the wording. All earlier studies used to say it is hardly 1%, 2%. But the current literature says for high potency drugs, it is high, 10 to 15%. That means we have to discuss about tardive dyskinesia. If it is mild, no problem. But if it comes in their way of functioning, yes, compensation will be asked. And it will be a civil negligence case, not a criminal negligence. So, invariably, tardive dyskinesia literature, it is high. It is not 1% or 2%, Dr. Ganesh, it is around 10 to 15% is the tardive dyskinesia. And 10% means invariably, our own psychiatrist, especially in NIMANS, will say it is very commonest, we have to discuss. So invariably, the compensation will be given. So at this point of time, there are meta-analysis available, and I can share those meta-analysis. And in this meta-analysis, prevalence of tardive dyskinesia is very high. So if it is mild, just a lingual dyskinesia or lips dyskinesia, nothing, there is no major issue. But if it is a total dystonia, that is basically there is a truncal dystonia which develops and is unable to function, then invariably, the compensation will be given. That's my response. And if the Montgomery comes, even it is 1%, we have to tell.
Any other questions?
Over to the organizers.
Any other questions from the PGs? Anybody?
Online and enlightened on a very difficult and challenging topic about the medical negligence and your presentation is very interesting. And we all take messages from your thing and we should inculcate in our day-to-day practice so that we'll be aware. And as Madam also pointed out, you also repeatedly pointed out, establishing rapport with the patient and the patient party, taking them into confidence will help us a lot. Yes, we sometimes knowingly or unknowingly something will happen, and yes, in the legal angle, people may take it in a different way. Ultimately, we will be worried about the immediate response from the patient party and the public, and that will hamper our day-to-day activities as well as our reputation. And ultimately, we may be proved right in the court of law over a period of time after a few years, but the damage will be done by then. So, any suggestions for us to go forward in this? And once again, I thank you very much for obliging our request to be part of the faculty. Instead of being in Switzerland, you agreed then, and I'm very grateful. From the Department of Psychiatry, I extend a very heartfelt thanks to you, Dr. Suresh. Vote.
Thank you, sir. Thank you for the point, and you requested to give me opinion regarding whenever there is a case, invariably if there is a death, something happens, the violence is there. Of course, the violence is not only with doctors, the violence, similar mob violence is there in any other case. It can be accidental case, road traffic accidents, the drivers will be beaten up. The simple reason is, unfortunately in India, the justice is not delivered in time. The people are losing faith in the justice. Once there is no justice, the people take justice into their hand or law into their hand. And I think yesterday some young boy has shot dead a Delhi-based doctor by a gun. So these violence are very common. There is a mob violence, and invariably our medias are showing the doctors are thugs. They are there to make money. So this kind of what we call it as the mob psychology increases the violence. So what to do in this regard? Again, RGKR Medical College is fighting for the justice with regard to providing a safe environment for doctors to practice. So we need to come up with our own guidelines or maybe security measures, how to have CCTV cameras. But even if there is a CCTV camera or maybe various other measures, maybe security guards, whenever there is a mob violence, even the police will not be able to control. So what to do, I also don't know. Of course, having CCTV cameras, all those things will help. And even yesterday I was discussing with Dr. Mahesh Gowda. Imagine if there is a death and the family says, I was in grief, I was shocked, my daughter died or son died. And I became emotional and I took law into their hand. Will it be a defense? No, it is not a defense. Under Bharatiya Nyaya Samhita, you may be angry, and many of this crime which occurs, it can be rape or it can be sudden attacking somebody. Brothers and sisters are fighting and they hit somebody at the height of the moment. That cannot be considered as a defense. The violence which occurs because of the mob violence or maybe because immediately after the sudden death, it cannot be used as a defense. At present, the Karnataka Medicare protection of medical personals, there is a very good law, but unfortunately till date, it is implemented in 2009, I think, if I remember. There is a non-bailable warrant, and the person who has caused a violence to the doctor or nurse, even intimidation, it can be, FIR can be filed. Till now, there is only one case, the punishment has been given. That means our doctors are not using. Why it happens? Simple reason is, if there is a death and the patient's family has attacked the doctor, there are 2-3 important things you need to understand. One is, the doctor is scared there will be a criminal negligence case against me. So he does not want to give an FIR. If you give an FIR, they will give a counter FIR telling that criminal negligence case. So the doctor is worried. Yeah. That is one reason many doctors do not want to file an FIR. Second, if he wants to file an FIR, invariably what happens is there is a political pressure. The public at large says, why their family member has died, doctor, why you want to give an FIR? That is the second. Third, if there is a fire, if there is an FIR, there is a death, if the doctor wants to give an FIR, immediately the police will threaten the doctor telling that you have done something, that the patient has died, you better give me money, and that it is easy way to make a bucks from by the police. And even in Rajasthan it is happening. Whenever there is a death or there is a complaint against a doctor, the police will go and threaten the doctor. Not only that, they have learnt a new way of threatening. They will arrest the doctor and also the nurses there. So if the nurses is arrested, maybe 3 or 4, the doctor is, you may arrest me, but I'll ready to fight. But if you arrest a female, think about their family. So I have come to know about a couple of cases in Rajasthan where they have to shell out around 5-10 lakh rupees so that the nurses are released. So this kind of ugly scenario is occurring. We need to sensitize our police, telling that what does the Jacob Matthew versus State of Punjab has said that case. You cannot arrest. The Tamil Nadu has given a clear-cut guidelines by the police inspector general telling that you cannot arrest. And we have to circulate this, the Jacob Matthew versus State of Punjab case report to all the police stations. And we need to have a good liaising with the police, talk to them nicely. The police chief in and around your hospital better have a good rapport, and Dr. Mahesh Gowda is the better person to discuss about this case, sir. But if there is a mob violence, it's very difficult to deal, and I would like to escape from that place. That is my personal opinion. Over to the organizers.
Excuse me, sir. Can you hear us now?
Can you hear us, sir? No. Any other questions we can convey it to him?
If someone wants to ask a question, we can call sir and...
Yeah, if there are no more questions, I think we can conclude the session. Thank you, sir, if he is listening. And thank you to the Department of Psychiatry from AJ Institute of Medical Sciences for giving me this opportunity. Thank you, Dr. Ravish, Dr. Kiran, Dr. Neela. Thank you so much.
I request Dr. Poonam to receive a token of appreciation from our department. I request Dr. Anil Kakunje sir to hand over Dr. Poonam a token of appreciation. Thank you, Dr. Suresh Badamat, for the compelling and informative session. Your exploration of the technicalities and crucial elements we must all be aware of has significantly enriched our understanding. And I also thank Dr. Poonam for chairing the session. So we shall now break for tea and get back here in another 10 to 15 minutes.
Hello friends, today we are going to discuss about medical negligence. I'm Dr. Suresh Bhagat.
We apologize, that was a glitch from our side. Please carry on.
Multa. Serious first.
ನಮ್ಮ ಡಿಸ್ಪ್ಲೇ ನೆಕ್ಸ್ಟ್ ಏರನ್ನ ಸ್ಪೀಚ್ ಉಂಡು ಅಕಲಕ್ಕಲ್ನ ಅವ ಡಿಸ್ಪ್ಲೇ ಅವಡು ಒಂದು ರೆಡ್ ಆಂಡಿತ್ತೆ ನೆಟ್ ಹಿಡಿದು ಮೇರ್ನ ಇತ್ತೆ ವ್ಯಾಲಿಡೇಟರಿ ಫಂಕ್ಷನ್ ಉಂಡು ಅವು ಇತ್ತೆ ಅವು ಆದ ಪಕ್ಕ ಒಂದು ನೆಕ್ಸ್ಟ್ ಸ್ಟಾಕ್ ಅದು ಏನಡ ಪಾಯಿಂಟರ್ ಉಂಡು ಒಂದು ಖಾಲಿ ಒಂದು ಒಂದೇಟರ್ ಬಂದ ಕಂಟಿನ್ಯೂಸ್ ದಾಲ ಹೆಚ್ಚು ಒರೇ ಬರ್ತಾರೆ ಸ್ಪೀಕರ್ ಅದಾಗ ಒಂಜಿ ಪಾಡ್ರೆ
ಅವರಿಗೆ ಒಂದು
ನಮ್ಮನೆ ಮಾತ್ರ ಒಂದು ಕಂಟಿನ್ಯೂಸ್ ಅದು ರಿಲೇ ಆಗ್ಬೋದು ಕಂಪ್ಯೂಟರ್ ಹಿಡಿದು ರಿಲೇ ಆಗ್ಬೋದು ಓಕೆ ಇಂಚಿನ ಇತ್ತೆ ಆಫ್ ಕೊಡ ಬೊಕ್ಕ ಇತ್ತೆ ಆಫ್ ಕೊಡ ಅವು ಬೋರ್ಡ್ ಪುನಃ ಏನಾರು ಬರ್ತೀರ ಬಂತೆ ಆರು ಆನ್ ಮಾಡ್ತೀವಿ We will now transition into the valedictory program. I now call upon stage Dr. Ashok Hegde, Dean, AJIMS, Dr. Sushit Shetty, Associate Dean, AJIMS, Dr. Ravish Tunga, Professor and Head, AJ Department of Psychiatry, Dr. Kiran Kumar, Associate Professor, AJ Department of Psychiatry, yes. Dr. Ravish BN, the speaker for today, Dr. Mahesh Gowda, Dr. Shubhankar Adhikari, who is an honorary delegate and he is an observer from the Karnataka Medical Council, To set a positive and reflective tone for this illuminating session, I would like to invite Swati, Dr. Swati, Dr. Samskriti and Dr. Vaishnavi, postgraduates from AJ Department of Psychiatry, to the stage for a prayer.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि गानचतुर श्रीगणेशाय धीमहि श्रीगणेशाय धीमहि.
Thank you, Dr. Swati, Samskriti and Vaishnavi, for that beautiful prayer. The pleasant melody truly uplifted our spirits. Now, it's my honor to invite Dr. Ravish Tunga, our distinguished head of the department, President MPS, and the chairman for the CME to the stage for the welcome address.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಮಾತಲ್ಲಿಗೆ ನಮ್ಮ ಮುಖ್ಯ ಸಲ್ಮಲು Good morning to everyone. It's indeed my pleasure to be in front of you to welcome each and every one of you for this very unique CME in psychiatry, that is law and psychiatry. Today, we are in a stage where we have to work within the frame of law. There was a time where patients used to believe us in faith like gods, and they used to accept whatever we do. But the scenario has changed. Of course, with the better education, with better understanding, better exposure, everybody has got a right to execute their whatever they due and get the best. No doubt about it. In the wake of this, and also following so many incidents in psychiatry or mental health field, the one we all remember is the Erwadi incident. Following that, the Supreme Court has taken a very serious step and also insisted our governance to implement certain boundaries and certain guidelines, certain standards to the practice. As a result of, we have one new law which has come. It has become an Act, Mental Health Care Act 2017. Because of COVID, the implementation got delayed, but now it's the time for us to know about it and go forward. Along with this, there are so many issues in psychiatry which we are probably having a blurred vision. So, keeping those things in mind, we thought we'll have a CME to enlighten not only the postgraduates, but also people like us who are in practice and also teaching, so that we can have a better knowledge. With that intention, today's CME has been planned, and we wanted to have the best people to take part in these deliberations, and we are fortunate to have them as well. Just as a first guest lecture, we had Dr. Suresh Padamat from Nimhans. You know, he's a lawyer as well as a psychiatry consultant professor, and we are fortunate to have him online in the morning. Then Dr. Ravish BMN and Mahesh Gowda, they are stalwarts in this field. So when we invited them, readily agreed and came for this. So we are fortunate. And today, with a short notice, we planned this program, though. For all our academic activities, our management is behind us. AJ College, AJ Medical College has supported us. Actually, college is run by the trust called Lakshmi Memorial Education Trust, and the president, Dr. AJ Shetty, directors, Dr. Sharda Shetty, Mrs. Sharda Shetty, and our beloved vice president, Mr. Prashant Shetty. He is there with us for all our endeavors and very supportive. And Mrs. Ashita Shetty, then Dr. Prashant Marla, who will join us shortly because he is stuck in OPD, and he is the medical director of our AJ Medical College, AJ HRC, and Dr. Amita Marla, she is the medical director there, and we have a tremendous support from the management for whatever the activities we are doing. My sincere gratitude for the management as always. For today's function, we requested Dr. Ashok Hegde, who is our beloved dean. He agreed wholeheartedly. When I initiated the talk with him, initially itself, he told I'll be there, and he is here with us. A very hearty welcome to you, sir, on behalf of the department. I request Dr. Kiran Kumar to offer a bouquet to sir. Very hearty welcome to you, sir. Dr. Sushit Shetty, he is our Associate Dean. He is with us for all our functions and he is here today. And hearty welcome to you, sir. As I mentioned, two stalwarts in the field of law and psychiatry are with us in person today to deliver guest lectures. One is Dr. Ravish BN, who is professor and head of the Department of Psychiatry at Mysore Medical College. He is my good friend. We are from the same institute, graduated and postgraduated, and we are happy to have him in Kudla. He is very fond of Kudla. Welcome to you, Ravish. And Dr. Mahesh Gowda, he is also alumni of Father Mullah's Medical College. He is the authority in this field. Whenever any problem of anything in legal aspect, one phone call to Mahesh Gowda will solve our problems. And we are happy to have you, Dr. Mahesh. In spite of a busy schedule, we know how busy you are in Bangalore, in Spandana, and attending such court cases and things like that. With this, all your expertise, we would like to have a best from you. That's why you are here. Hearty welcome to you. I would like to share that we have got one Karnataka Medical Council credit point for this program, and it has been granted. And to observe the proceedings, Dr. Shubhankar Adhikari is with us. He is faculty in the Community Medicine Department, NOPI Medical College, and a hearty welcome to you. I personally welcome Dr. Kiran, who is a backbone of our department. He is Professor of Psychiatry and he is with us on the stage. And at a personal front, I welcome Dr. Kiran. Faculty, yeah, please. I will. We have chairpersons and we have a panel discussion. Panelists have come already, quite a few have arrived and few are yet to arrive. And there will be a very good deliberations and also discussions to follow. I wish all of you to have a very fruitful learning, to enlighten us. People who have worked in this field and also good academicians have come. Starting from today's first talk, Dr. Suresh Badamat online. We thank him. And Dr. Poonam, she came all the way from Surlia to chair the session. Welcome, Poonam. And Dr. Samir Praharaj has come from Manipal. He is professor and head of the Department of Psychiatry at KMC Manipal. Welcome to you. And also Dr. Ravindra Manoli, who is the additional professor. He has come from Manipal, KMC Manipal. Welcome to Dr. Manoli. With just one phone call, they all readily agreed. And Dr. Madhurao will join us shortly. He is going to moderate our panel discussion. And as panelists, we have quite a few very eminent people to enlighten us. As I told, Dr. Samir will be there. Dr. Keshav Pai, he has already come, I think. Yeah, Dr. Keshav Pai, hearty welcome to you. Dr. Aruna Ediyar, she is also come. She is the professor of psychiatry at Father Mullah's Medical College. Welcome to you, Aruna. Dr. Keshav Pai is head in the department at KMC Mangalore, where I was there earlier. Dr. Ganesh Prasad Mudraje, he is our close friend and he is always there for us to support. He is from Puttur, consultant psychiatrist at Puttur. Welcome to you, Ganesh. And our senior colleagues are there. Dr. Satish Rao sir has come from Kshema. See, I think he is one of the first one to come to the program today along with Dr. Nishi. And all others who are all here, consultants from different medical colleges are here, and our AJ faculty members are here. Hearty welcome to you, each one of you. Dr. Sunil has come from Wenlock Hospital to run our senior psychiatrist. So, I mean, I can't name each and every one. And it goes without saying that our department is doing a wonderful job in both our day-to-day work as well as in such occasions. And our department, starting from Dr. Neela, Madhavi, Ashwini, Vidyashri, and all our postgraduates, they did a wonderful job. And in we are there to guide. Me and Kiran are there to guide, but they did all the things. Whole credit goes to the department postgraduates and other faculty in the department. Thanks to you all for chipping in and doing your bit. And yeah, so from different institutions, all of you have registered, and I think online, it's a hybrid mode, and online also people are viewing, and welcome to each one of you who made it for this function, and thank you very much. Have a good day and have a good learning. Thank you.
Thank you, sir, for your warm and insightful words. Lighting a lamp symbolizes knowledge and the dispelling of darkness. With this in mind, I invite our esteemed dignitaries on the dais to light the lamp, illuminating our journey of learning and collaboration. Moving forward, it is my honor to introduce Dr. Ashok Hegde, the esteemed Dean of AJ Insttute of Medical Sciences and Research Center. As a distinguished general surgeon by profession, Dr. Hegde has dedicated his career to advancing medical education and practice. His leadership and commitment to fostering a culture of excellence within the institution have significantly impacted both student and faculty alike. We are eager to hear his insights today.
Dignitaries on the dais, off the dais, my dear delegates, and all those who have gathered here, good morning to one and all. I consider it as an absolute honor and privilege to stand before you as we inaugurate this important continuous medical education program organized by the Department of Psychiatry in association with the Mangalore Psychiatric Association. As medical practitioners and the lifelong students of medicine, we are all bound by the principle that learning never stops. This is more so in a complex field as psychiatry. I take this opportunity to congratulate the Department of Psychiatry, Professor Dr. Ravish Tunga, Head of the Department and Organizing Chairman, Dr. Kiran, Organizing Co-Chairman, and Organizing Secretary Neela Bami Shanai, and all my esteemed colleagues, office bearers, and the members of the Mangalore Psychiatric Society for organizing this meaningful program. In the field of psychiatry, we are entrusted with the immense responsibility to take care of the mind, arguably the most complex and least understood part of the human health. The need for continuous education is really needed in the field of psychiatry because it's a fast evolving field with a lot of discoveries which are helping us to reconsider the illness and its treatment. Today you have organized a CME on law and psychiatry to know the more nuances of the new laws which have been introduced. You have invited scholars to share their vast wealth of their knowledge. I call upon all the delegates to make the best use of today's CME and propagate this knowledge to others. I take this opportunity to wish the CME a grand success. Thank you.
Thank you, sir, for your thoughtful remarks. We appreciate your valuable contributions to this event. It is now my pleasure to invite Dr. P.K. Kiran Kumar, Professor of the AJ Psychiatry Department and Co-Chairperson of today's event, to deliver the vote of thanks.
Good morning, everyone. On behalf of Organizing Committee, it's my privilege to propose the vote of thanks for today's CME, the Law and Psychiatry. I would like to begin by expressing my heartfelt gratitude to the management of our institute, whose support has been instrumental in making this event a success. Our beloved President, Dr. A.J. Shetty, who has been a pillar of strength in all our endeavors. Thank you, sir. Mr. Prashant Shetty, the dynamic Vice President of LMET, for his continuous support for this event. Thank you, sir. We are grateful to the support of Srimati Sharada J. Shetty, Director, LMET, Dr. Prashant Madla, who will be joining us soon, Medical Director, AJHRC, Srimati Amita Madla, Director, Administration, AJHRC, for their support. I also thank our Dean, Dr. Ashok Hegde, and Associate Dean, Dr. Sushit, for their involvement in all our academic activities of the institution. Thank you, sir. Your guidance and encouragement has been vital success to the CME, and we are sincerely grateful to you. I would like to, Dr. Ravish Panga, to present a token of gratitude to our Dean and Associate Dean. I'd also like to extend our appreciation to MPS for their continuous commitment and collaboration, which has enriched the quality of our discussions and strengthened our professional community. Our heartfelt thanks to Dr. Suresh Badaman for his invaluable contribution to the CME. Despite his busy schedule and other commitments, he made time to deliver an insightful talk on law and medical negligence. His participation, even virtually, has greatly enriched our understanding, and we are deeply grateful for his presence today. Chairperson Dr. Poonam has set a standard for the rest of our day's discussion. We are grateful to Dr. Ravish Bian, who will be addressing the critical issues of legal challenges in telemedicine health, chaired by Dr. Ravindra Manoli. Thank you. Dr. Mahesh Gowda, who will share his thoughts on violence meted out on doctors, where are we headed, chaired by Dr. Srinivas Bhatt. Additionally, I would like to express my sincere thanks to the panelists for the upcoming panel discussion on the Mental Health Act 2017, the way forward. We are honored to have Dr. Suresh Badamat, Dr. Ravish Bian, Dr. Mahesh Gowda, Dr. Keshav Pai, Dr. Samir Kumar Praraj, Dr. Aruna Idiyad, and Dr. Ganesh Prasad, who graciously agreed to join us. This panel discussion will be chaired by Dr. Madhav Rao, who will be joining us soon, I think. And we are eagerly await the valuable insights that will shape our understanding of the future of mental health care in India. Our heartfelt thanks again goes to Dr. Ravish Tunga, who is the brain master of today's event, the Professor and HOD of Psychiatry, Department of Psychiatry, AJMS, President of MPS, and also our dynamic Assistant Professor, Dr. Neela Bami Shenai. She is also Organizing Secretary of MPS for their effort in organizing this CME. Additionally, special thanks to Dr. Madhvi, Dr. Ashwini, Mrs. Vidyashri for ensuring the CME was coordinated so efficiently. Your dedication behind the scene is truly appreciated. I would like to extend my gratitude to Dr. Smriti Shetty, HOD Department of Physiology, who has been instrumental in coordinating everything from the initial stages, and our Deputy MS, Dr. Sachidanand, for his support throughout the event. I thank Dr. Shubhankar Adhikari, KMC CME Observer. He is the Associate Professor of Community Medicine, Enapoya. Thank you, sir. A note of gratitude goes to all postgraduates, especially Sandesh and all team, for their invaluable assistance throughout the CME. Your efforts have played a key role in the success. We also express our sincere thanks to Inter Pharmaceuticals and Ipca Pharmaceuticals for their generous support in conducting the CME. Your commitment to advancing mental health care is truly commendable. I'd like to thank the Moti Mahal for the excellent refreshments and extended our appreciation to the maintenance, housekeeping and EDP department for their support in maintaining a clean, comfortable and well-organized environment. Additionally, I would like to extend our gratitude to Namana channel for helping with the broadcast of the session. Finally, to all the participants, thank you for your active engagement and thoughtful contribution. Your presence is what makes this CME truly meaningful. Thank you one and all.
Thank you, Dr. P.K. Kiran Kumar, sir, for your considerate vote of thanks. Your words truly capture the spirit of teamwork that has contributed to the success of this event. We would now like to conclude the validatory program and move on into the next speech.
ನೀವು ಇಲ್ಲೇ ಇರ್ತೀರಾ? ಇಲ್ಲೇ ಇರ್ತೀರಾ? ಅಲ್ಲಿಡ್ತೀರಾ?
Just in case it doesn't, like, because this thing, while setting up only lot of problems, if you directly put it to this, then it will be easy.
So I can handle here.
Yes, you can use this point.
Yeah, that also. Action one ಕೊಡ್ರಿ. ಆಡಿಯೋ ಉಂಟು, ವಿಡಿಯೋ ಉಂಟಾಯ್ತು. ವಿಡಿಯೋ ಇದೆ.
Try if the video is working. Like if you want, we can try it once.
ಟ್ರೈ ಮಾಡಿ. ಇಲ್ಲ ಒಳ್ಳೆ ಮಾಡಿ ಇಲ್ಲ
Where are you petrol?
Okay, good.
Introduce the chairperson and then
Yeah. Start with it. I want this thing, cordless mic.
yes, the attachable on the.
That is also fine, whichever. Fine.
Do you prefer this one, sir? Attachable body one?
Hello. Hello. Yeah.
Up to the chairperson, you can manage.
I will start. Yeah. Good morning. We have just concluded the inauguration. We will move on to the next session. I am Dr. Ravindra, Additional Professor of Psychiatry at KMC Manipal. Without much delay, we will just go ahead with the introduction of today's speaker, who is one of the very passionate person, passionate about anything that he does. Okay, so I have his CV and all. There are many things to read. Before that, I will tell. So he is a man in search of meaning, what we call. So recently, he discovered some more meaning to his life and existence. That's what I can say. When he went on searching his roots, he came to know that he is one of the descendants of Talakadu Ganga dynasty. So probably then he realized that the passion that he has is maybe because of his ancestors or the genes that have been passed. He belongs to the what we call soldiers or warrior family. Okay, so those what we call genes and traits have been passed on to him. So who is passionate and he fights for the rights of the people. Okay, fights for the rights of everyone who is doing good. We have Sir CV here. He has more than 15 degrees. He is professor and head department of psychiatry at MMC Mysore. He was former director of DIMANS Dharwad. One notable contribution or some initiative which has during his tenure he started at DIMANS was about Raita Chetana program. Even if you go now to the website, you will see that there is a Raita Chetana program which he has initiated to prevent suicides in the farmers. That is one of its kind initiative in India, so which needs to be applauded and because something unique which has been done at that time and it's still being followed. So that brought some major change. Another important thing is his member to European Violence in Psychiatry Research Group. So, Sir has collaborated with the European group and he conducts conference alternate year here in India and Europe also. Sir has received many awards. He is the International Associate of RCP UK, Young Fellowship Award, WPA and Zone 4. In Venezuela in 2006, he received Young Scientist Award, Social Scholarship, ICMR Grant, Young Psychiatrist, Young Teacher Award. So you can see the number of awards that he has. So that itself is a testimony that how well and how diversified his interest has been. To his credit, Sir has more than 84 publications and he has authored 4 chapters in the book and he has written 3 books in Kannada and one more book is about Ganga Sri Purusha, about his ancestor that he has written. Sir had served as a president of Indian Psychiatric Society Karnataka chapter. So he is chairman of many other committees and nodal members, so I will skip that, sir. So straight away we come to the topic about the legal aspects about telemental healthcare that we are giving. Okay, so we worked on this area some time ago when we wrote an article on this topic also somewhere in 2020, I think so, 20 or 22. So now I request Professor Ravish Vien sir to take over the session from here.
A very good morning to all of you. Only Dr. Satish Rao said good morning. Good morning. Thank you, Dr. Ravindra. ಕೂಡ್ಲಾಗ ಪೀರ ಬಂದಾಗ ಎಂಕಲ ಅಪಾರ ಖುಷಿ ಆಪುಂಡು. ಈ ಅವಕಾಶ ಕೊರದು ಲೆಪ್ಪುನ ಎನ್ನ ಗುರು ಡಾಕ್ಟರ್ ತುಂಗ ಅವರಿಗೆ ನಮಸ್ಕಾರಗಳು. ಬೊಕ್ಕ ಎ.ಜೆ. ಶೆಟ್ಟಿ ಇನ್ಸ್ಟಿಟ್ಯೂಟ್ ಆಫ್ ಮೆಡಿಕಲ್ ಸೈನ್ಸಸ್ಗೂ ಧನ್ಯವಾದ. I spent my 10 years in Akanda Dakshina Kannada. That time still it was not Udupi. So I call it as my Tavaru Mane. I feel like coming back again and again. Anyway, we already have shortage of time. Suru Malpura Munche, Dumbu, Vanchi, Kudla the Jalak. It's not working.
Where are you, Prajwal? When are you going to submit the report? It's already late.
Sorry for the inconvenience, Johnny.
Yeah, I will submit the report by EOD. Hey, Prajwal, where are you? I can hear some noise.
Actually, people are drilling holes near my home. That is the noise.
No. I want to see your face. Please turn on your camera.
Anyway, I don't know how much you heard. In fact, the boss wanted him to show the face. That's the message. Telemental health or telepsychiatry. I think most of us think that only after COVID this has come to the fore, but in India this was way back started by SCARF, called as SCARF Telepsychiatry in Pudukottai, following the tsunami which we had in 2004. So this was one of the first instances. And then we have a lot of models. Neman's model, I think Manipal has got a very good model, Chandigarh. So I don't want to go into the models, how they have been done, but one should know the types. One is the interactive or the synchronous one, the other one is asynchronous one, which is a store forward. Okay, you can respond once you see the message. Many psychologists have started telepsychotherapy, and telepsychiatric education is quite popular. Even the government agencies are taking up these activities. This is just the introductory slide. Now I want to go point by point without wasting much time. Now, does telepsychiatry have a legal recognition in India? Yes, it has. It's not working. It's not working. So, in 2020, telemedicine guidelines came up, which was recognized by the Ministry of Health and Family Welfare, and also it was recognized by the Niti Aayog along with the then Medical Council of India, and then it has been gazetted and then it has become a statute. Now for psychiatry, along with Indian Psychiatric Society, Telemedicine Society of India and NIMANS prepared a standard operating procedure. I think you can find it in the net exclusively for telepsychiatry. So in the morning we heard that guidelines are so important. So this is definitely an important guideline for any psychiatrist who wish to practice telepsychiatry. Licensing and accreditation. Let us understand, we don't just get limited to Mental Health Care Act, we come under all the medical jurisprudence. Like a physical consultation, teleconsultation holds good with all the accessories laws. Okay, the law of the land. Don't just think section 25 related to documentation is holding good. I say MHCA 2017, okay, right and right you need to understand. There has been a mandate with regard to an online course. I think proposals are coming for the postgraduate training in telepsychiatry, because we never know when we may have to take up, because partially you may have to do in offline consultation as well. What is important? See, when you go to the court of law, the first question will be asked is your name, your designation, your age, and then your years of experience, your training. So all those things you need to display. Okay, this validates. If possible, okay, you may have to display your licensing, or like when you seal, you have a KMC number. So that's a prerequisite for licensing. Now, informed consent. Many people have a confusion that once the patient contacts you online, that means there is some kind of an implied consent, that he has definitely agreed. No, that doesn't hold good. You need to have an explicit consent, and there has been a consent form, okay, in the operating guidelines. Covert audio and video recording by anyone in telepsychiatry is illegal. That means to say, you have to maintain these data, digital data, and that needs to be informed. And before that, you need to take a informed consent. So I've just given a picture of exactly what is there in the operating guidelines. You can definitely, it's a free access. One thing you should always be cautious is when you are talking to any subject. I'm using subject, okay, some prefer client, okay. Some may say, okay, patient. So it all depends what you want to really, what the patient really wants. Whether the subject is in conflict with law, then definitely, okay, you have to be little bit defensive and then maybe call in-person consultation. So consent is a must, and I will tell you what exactly the consent means with the new Data Protection Act only last year before the government, the federal government finished its term. So what was because I'm going a little bit fast, what was the first point? It was about legal recognition. What was the second one? It was about licensing. What was the third one? About informed consent. Then comes data privacy and security. Okay, until unless you are equipped with this, okay, otherwise you will be in deep trouble. So Data Protection Law, the Information Technology Act, which was amended, okay, IT rules in 2011, okay, patient confidentiality. No, actually there's a change. I think in the pen drive I didn't update it. Anyway, fine. So this is not a bill, it has been passed as an act, okay. Maintaining medical records, identification, location of patient. Now, this is Appendix 1, means when there is a new consultation, how the pro forma needs to be. Okay. So here all the patient details, then with what complaints that he has come, then with regard to the physical examination and other findings, finally the consultant's remark. So this has been taken from the Telepsychiatry Operating Guidelines 2020. The follow-up consultation also needs similar kind of form, but you will actually add, I'll just see if I have added some of the points, otherwise, yes, I have added, okay. So why I'm insisting these things is documentation and documentation protection makes a vital defense for you. Okay, as we kept on telling, that is duty of care. Okay, so we need to understand this. Now, this is with regard to the psychotherapy. Okay, and psychotherapy has a different consent form. So what type of therapy, all those details will come here. So I've seen many counselors, okay, so-called counselors doing therapy online. Now prescribing medication, this is a typical online prescription, okay, whether you send it to the pharmacist, probably in-house such kind of a infrastructure, you can definitely send it to the pharmacy, but otherwise you may have to send it to the patient themselves. But you will have to stamp it, okay, keep one copy with you and then one copy to the patient. What is important is understanding the list O, A, B and C. List O I'll be mentioning later. Most of the difficulties, legal challenges are related to, one is consent, second one is e-prescription. So list O is over the counter, okay, list A is basically during the first consultation. List C is something which is coming under NDPS Act, so it is prohibited to prescribe online. So you come under definitely NDPS Act. Many psychiatrists themselves dispense drugs, okay. So that requires certain legal fulfillment. Okay. Now what is a list O drug? So all these things. Okay. I don't think anybody really gives a prescription for this. This is list A drug. Okay. This is for the first consultation. So antidepressants, you have only 3 of them: imipramine, escitalopram and fluoxetine, mood stabilizers, oral antipsychotics. Okay. So only 3 injectables: flufenazine, haloperidol. That too, not a long acting. Okay. So this, while you are prescribing this, whether you are mentioning it to a registered medical practitioner or a health worker, you need to be careful. If it is a health worker, you need to be very sure that, okay, that the person is equipped enough to give an injection. Now zolpidem and lorazepam, we all know clonazepam was later on added to this drug, to this list. Okay. Zolpidem and lorazepam come under Z drugs, and long-acting injectables are not preferred. This is list B. Okay. This is, the list is dynamic in nature. That means it is only a provisional one. Okay. This is given during tele-follow-up consultation only, or when you see face-to-face consultation. Okay. List C drugs prohibited for online prescribing. So that is the scheduled X drugs. Okay. Those which come under the NDPS Act. So the online prescription, again you have to maintain the IMC guideline. So prescription is something quite important. Now, actually I had mentioned about, I had done that on my laptop. I forgot to upload it in. So there is this criminal negligence which was mentioned by Suresh Badamat, that is IPC 304. Okay. Now IPC 304 has been changed into BNS 106. 106 has been divided into section 1 and 2. I am not trying to complicate things. What I meant to say is, you will have similar punishment, okay, as that has a physical consultation. Okay. So that is when there is a damage. Now suppose if a death happens, again there is BNS, okay, Bharatiya Nyaya Samhita sections. Then culpable homicide, okay, grievous hurt, all those things has got different ones. And let me tell you, there are many case laws that have been decided in the court of law. And one of the case laws before COVID was in the state of Maharashtra. Okay, when the doctor, without examining, he gives instruction to the nurse. Okay, it was again a gynecology case, and then the patient dies, okay, with the complication. So doctors were held liable because they didn't directly examine the case. So this professional negligence, a new terminology has come into medical jurisprudence called tele-negligence. And professional misconducts, okay, whatever the errors that happen, what you are not supposed to do, okay, all those. Most of the time it will be medical errors, okay. Now jurisprudence issues. I know most of the catchment area, earlier Kasaragod and other regions would come to here. So if you have a consultation, okay, patient is in Kasaragod, definitely the judicial, because health is a state matter. In the constitution, right to health comes under the state matter, not the union list. So that's why even in my district, okay, see the Wayanad, any tertiary care, they would come to Mysore. Even the Nilgiri, okay, Mysore is much more nearer. And to reach physically, okay, coming by vehicle, it's easy to connect digitally. So across the states, definitely, okay, there is difficulty. You need to fulfill the other state criterias. Cross-border, that is beyond a country, definitely not advisable. Reimbursement and insurance coverage, payment models, you can charge the way you do with a physical consultation. Now with regard to insurance policies, whether it is for you, okay, the indemnity, or whether for the patient coverage, that needs to be specified when the contract has been gotten into. Okay. So there are so many, third parties who tend to lure you, okay, to use their portal. Okay, you have to be careful with what kind of contract that you will get into. And particularly, one of the important thing is sensitive data with the third party is always dangerous. So how the data has been protected is something you need to be careful. And we all know that the Indian Medical Council way back 1956, okay, false advertising and fraud, we all know certain claims. See, unfortunately, these claims are done by quacks, even in the religious matters, okay. 100% parihara, illa andre dudu vapas. Okay. So, the client expects the same thing from the doctor, quick and complete. Okay. So some of them, I really wonder what is the role of life coaches. Okay, they are aggressive life coaches. I'm yet to understand my life. Okay, but still, these people say they aggressively do it online, and then finally, whatever the damage which was mentioned in the negligence, okay, duty of care, damage. So you will be liable. See, we are bound with so many boundaries, but unfortunately these quacks, okay, get away. So something which the societies, okay, like Indian Psychiatry Society or IMA has a huge role. So technology providers, definitely you need to have a proper memorandum of understanding before entering into the So there is both platform liability, the third person, and also whatever the medical device regulation. See, in fact, in such a huge setup like AJ Shetty had a difficulty in having a online, it happens. What I meant to say, it happens. So these are all the limitations which I will mention. Okay. So don't do exclusively teleconsultation. It is my legal advice. Okay. Like if you want to extend with a relaxed way, okay, then you have these teleconsultations where there is least challenge. Okay. Like follow-up, you don't have to make the patient really come and, physically present. So limitation in handling the emergencies, physical examination, okay, whatever said and done, this may be equivalent to understanding the physical findings, but still, until you observe, you see the texture, because everything matters, the lighting, okay. If someone wears the glasses, okay, the light reflecting, so lot of these nitty-gritties are involved in teleconsultation. So follow-up care, again, what has been mentioned is whether in the absence of patient, a NR can come, okay, or any other legal guardian can come, okay. If it is a child, again it's a big challenge. So sometimes, okay, just for refilling the medications, okay, they may call. So you have to be aware of follow-up care misuse, digital technology, digital literacy, okay. Many a times the updates which come, okay, we are not aware about. Digital etiquette is something most of our Indians, okay, we don't have. That is something nobody teaches us, okay. It's not taught in a formal way, in any form actually. So those are all the limitations. See, telemental health in India has mainly with regard to the licensing, data privacy, prescribing regulation, the liabilities and jurisdiction. These are the critical areas. See, the legal environment is growing with the Digital Protection Act that has come in 2023, which is quite stringent in safeguarding the data. Teleconsultation or otherwise is left to the professional judgment of the RMP. Please understand this. If you are in doubt, okay, it's your prerogative to call them for a physical consultation. Can never be under any kind of dakshinya, okay, because our patients are masters of giving excuses, okay, stories. So we all play for the sentimental cards, okay. I think when if you listen to Mahesh, you will become so immune that not only every patient stepping to your consultation, any patient contacting you is a potential litigant, okay, I can say that. So these are my references. As Ravindra said, we had ethical and legal aspects of telepsychiatry in Indian Journal of Psychological Medicine 2020. And the other one is this one. This is the website, okay. If you type telepsychiatry operational guidelines, it is quite good enough to understand what are the areas where you need to be careful. It has given a section where legal challenges, ethical and legal challenges are mentioned. Okay, so it's Dasara time. So I wish you all the 9 goddesses, okay. Dakshin Kannada, Akhanda Dakshin Kannada, I remember only Saraswati, but nowadays Lakshmi also has started flowing. It is one of the prosperous districts in Karnataka, other than Bangalore.
Thank you, sir.
Thank you very much.
Thank you for that wonderful lecture. So now the topic is open for discussion. Any queries? Yes, many postgraduates, they should be asking more questions because they are more tech savvy and they will have more concerns. Yes, Ganesh sir.
Ravish, a very good presentation. I have a question with regard to WhatsApp prescription, follow-up prescription. Many patients, they come and after residing in remote places, they ask for follow-up prescriptions. Sometimes we tend to send follow-up prescriptions through WhatsApp. How legal it is? What are the careful issues we have to be in that scenario?
Actually, I didn't mention about social media consultations. It is also a part of telepsychiatry practice because it becomes an asynchronous way. So if you send a prescription, it is valid. Okay. Now the question is, the issuing pharmacist should also have that copy, and then probably it has been dispatched, something like that he has to maintain, because that prescription cannot be reused or multiplied, number one. Second thing is, you need to maintain that data that you have issued. If it is a mixed, like only for sometimes you send WhatsApp prescription, sometimes they come for physical consultation, then you can take a print and add it to the document and you need to preserve it. Otherwise, it has a legal recognition of a proper prescription.
Do I need to take a consent for that also?
Yes, of course.
Because before sending WhatsApp prescription, whether I should ask his consent from the patient side. Because it is a follow-up.
Doesn't matter, you need to take a consent.
At times, the family members may ask for this prescription because patient themselves may not be able to brought or some other things. But what they mention is when the person comes for the first time. So probably if the distance is an issue, that they can take a consent and write up. So also they mention about how we define the first consultation and the follow-up consultation in the SOP that they have mentioned. First consultation, they mentioned that the person has visited for the first time for some ailment, then he is coming within 6 months for the same ailment. That is considered as first consultation or follow-up. If the person is coming after 6 months, within 6 months person is coming again and again, first and follow-up will be, that's it. If the person comes again after 6 months, that is again considered as first consultation. Okay, that won't be follow-up.
No, but routinely we don't take consent in OPD.
No, we can just either document.
We just give the prescription. We don't take consent for OPD prescriptions.
No, we can just write somewhere there, sir. But documentation is essential, that's it. See, by default we can understand that whatever rules or anything that are applying in-person consultation, almost everything will apply here. In addition, rules or regulations are for intermediaries. Intermediaries are the platforms which are providing services like to technical services. They are advertising for ourselves and all. Even there are rules like how we should advertise, how we should not advertise, what we should be put. Many times we see like so many star marks are there or somebody has given feedback. All those are not to be done as per the operational guidelines. That is essential.
I think what happens is when you're using a platform for seeking consultation, for example, if you're using a third-party vendor, there's an underlying consenting process there that he agrees to certain terms and conditions when he's taking your appointment. So those things can be specified there, and by paying your fee and seeking an appointment, it is an implied consent. So in OPD practice, most of it is implied because we don't document. Whereas it's a procedure, yes, we have to really document. In WhatsApp, what happens is he'll just call and you do a consultation. We don't have a process there.
Yes.
Ideally, I think it should be on a platform where there's an underlying terms and conditions specified. I think that's safer for us.
No, usually you shouldn't be using the same WhatsApp or social media that you generally use. If you are using it for teleconsultation, it should be specific teleconsultation WhatsApp. You can't mix it up.
Yeah.
You can't mix it up.
Also they mention, let's say if you have a Facebook account or anything, so they want it to be like your personal profile should be different. The one which you are using for either like to dispense information about mental health or using it for any of the consultation, anything, that should be totally different. So that has to be ensured. And as sir was mentioning, intermediaries will take care of these consenting and other process by the time they reach there. Sir also mentioned about the fees. So the guidelines also mention that how much fee is there, that should be clearly mentioned. Let's say 500 rupees, how much you are getting, how much the platform is getting, that also has to be mentioned as per the guidelines. So,
and the timing for how long?
Dr. Vish, it was a wonderful presentation. You covered almost all the aspects of the teleconsultation part. One doubt always I have, I don't know whether the first ever consultation, after 6 months first consultation, for a legal purpose you may be saying that, but to be the continued consultation. First ever consultation, isn't it mandatory that we should see the patient in person? Because we always have a fear of missing something physically, maybe comorbidities, or maybe the depression may be because of the underlying medical cause. So suppose the patient has hypothyroidism and later comes to the depression, teleconsultation itself is the first consultation, and later if it found to be a result of hypothyroidism and if it is neglected, don't it become a negligence? And should we have the disclaimer in the beginning itself in a consent that we are not responsible for the...
No, if you see in the limitations I mentioned about that, but in the pro forma, in the first consultation, all those biochemical investigations he will have to upload and show it to you. Okay, he would disclose everything. If you have doubt, you can also ask for such investigations. Despite of that, you have a doubt, then you request the patient to come for a in-house consultation. But it all depends on the judgment of the treating psychiatrist.
Now, what if from a legal angle, what if we miss it and later the patient claims that, oh, you should have told that earlier and you missed and sue you?
That's what. One comes the competency, second comes the patient's capacity, the consent and other things. And third one is your judgment. Okay. So, all the three are important.
At times because psychiatrist is not able to do a physical examination, let it be follow-up or any of the consultation, they suggest them to visit the nearest clinical service or clinical set of physician with whom we want to liaise and get the feedback what the physical ailment that the person has. As we mentioned, the first consultation should be in person always, so then we call for follow-up on the telepsychiatry. And also they mentioned that it's not that because I have mobile and he has mobile 10 kilometers I want to do telepsychiatry. No. There should be a valid reason why do you want to go for telepsychiatry. So that also has to be specified.
No, with regard to negligency, unless it's a gross mistake, that is what it's mentioned. So then only it becomes negligence. If you have inquired and if the patient has not given the information, then it becomes liability of the patient. But your recording, and if you have doubt, as Ravindra was mentioning, you can ask them to consult the nearest RMP and then come back with the report.
Ravindra, you have a vast experience of doing this telepsychiatry. Like our Ravi sir was asking, have you come across any complications secondary to this telepsychiatry in your experience?
In our setup, so we have a little modified version of the telepsychiatry that we run. So we have a MOE with the government and a MOE with the PHC and the doctors who are there. We modified in such a way so that it can act as a training module for students also, where one of the JR goes there, sees the patient in front of us, which we observe. Okay, so they will be interviewing in front of a laptop, so we are observing. If required, we will also interview the patient and service is delivered. Here the legal aspects are taken care in terms of like we have a MOE with government, medicines are prescribed from the government hospital. Then one of the qualified doctors, at least MBBS doctor, is going there and interviewing the patient trainee. So most of the legal hurdles have been addressed in this. As we mentioned, some complication, because that was not came up here, because if you read a little bit in detail, let's say I do a telepsychiatric consultation, patient develops some adverse effects, then what to do? Because one of the reason for seeking telepsychiatry is distance. Patient is in a remote village somewhere, patient develops dystonia, then what to do? So these are some practical problems. So for that we keep in loop of services available there. Okay, so some of the nearest hospital and all, we keep the numbers of them. In case of such emergency, they rush to the government hospital or they will call up one of the contact person. So we tell them. So it has happened, like one person developed dystonia, then immediately within half an hour we were able to reach out to the private practitioner, then thing was sorted out. But apart from this, no other legal issues have popped up. So, yeah.
Sir, in those that resort to telepsychiatry, the length of the prescription, like what is the maximum duration that we are allowed to issue a prescription for? How frequently should we ask them to follow up with us? And also it's not connected to this, but if you could tell me legally, even in...
So invariably the practice guide, the guidelines that you mentioned, so they won't allow more than 3 months or 6 months. So, okay, so regular guidelines which are there, the same will apply here also. So they insist to come as well. But what we practice is once a month, that's it, no, not more than that. And that too when we see the patient, then only.
But 3 months is legitimately allowed?
3 is allowed.
Okay.
But you need to caution them that if there is a new symptom or if there is any adverse effect, immediately to contact you. So that caution, what you have given, has to be documented.
Thank you, sir.
Yeah. there are no more questions. Yeah, he has a question.
Sir, what are the guidelines about prescribing for patients who are abroad or overseas?
You see, where is your jurisdiction? That's it. I can't go and prescribe something in Kerala also until unless I have a code registration there. I can't go and do it in Maharashtra. So abroad also the same thing will apply. Okay. You may prescribe, but you will end up in problem if something happens. That's it. Okay.
Sir, two questions. First one regarding the license. Who is the licensing authority, if at all we have to apply? Or is it just the license that we have for our clinic that is sufficient to have a teleconsultation? Second question regarding the indemnity insurance, professional indemnity insurance. Does that cover for the telepsychiatry also?
Yeah. So, see the first thing that you are mentioning about what license you have. So your registration is there, that's it, that itself is license. Now, telepsychiatry operational guidance, they mentioned that they will come up with a training which you have to complete and get a certificate to be qualified. So they told they will develop that module for licensing within 3 years, but still that has not happened. So till that time you can continue the existing with our service. So that shouldn't be a problem. And second thing is about having an intermediary or the platform which you want to use. So go for something like there are many vendors available now where you want to enlist yourself. So you can customize it for yourself and proceed. So some of them are there. I don't want to take name on this platform. So you can approach them. So let's say for an annually, even for the in-clinic and for telepsychiatry, everything will be there in particular software. They will charge around 10,000 or 15,000 per year, including keeping the data at everything. And again, the data, because you need to store the data at least for 3 years as per the guidelines in telepsychiatry operational guidelines. All the data, all the OPD, inpatient, whatever you have, for 3 years at least you need to store. So when you go with these vendors some vendors are working only for psychiatry. So they will take care of all this as per the MHCA compliance and these guidelines.
And the indemnity insurance, sir, do they cover the
insurance? That's still an issue because they are not covering in-person consultations also. So how can we expect this? So if you need to do, yeah.
Dr. Mahesh has a proposal. In Ipsocon, he has a kiosk where up to 5 crore, I think he can highlight about that.
Yeah.
Just to cover indemnity, most of us practice fearlessly to make sure that this fear is actually catching on us and fearlessness should really remain with us. We are trying to generate an indemnity policy. At Ipsocon, we are going to have a kiosk where by paying 10,900 rupees, you can get yourself covered for 5 crores and it will also have an additional medical legal coverage because you need to have a strong company with good lawyers who understand medical legal sensitive issues. So there's a company called Dockland. So IPS is trying up with them and we're going to set up this kiosk in Bangalore.
See, those kind of indemnity are definitely better because some insurance companies have a clause that asterisks and conditions apply. If any actions turns out to be illegal, then it is not covered under indemnity. So we have to read the conditions before entering into this contract of indemnity. It's just a word of caution.
And the unique thing in this insurance, what Dr. Mahesh sir has mentioned, was about the legal aid availability. Yeah. So, because many times when something comes upon us, we don't know where to run away. Again, we end up calling Mahesh sir only. So, but here legal aid is also covered in this. So, yeah.
Thank you, sir.
Thank you. I think this is last question. I thank Ravish Tunga sir and the whole team of Department of Psychiatry of Age Institute of Medical Sciences and Research Center for this wonderful opportunity. So we'd always love to come to this place. Okay. Thank you, sir, and thanks to Ravish, sir.
Sir, I request Dr. Ravindra Monoli, sir, to hand over a token of appreciation to Dr. Ravish BN, sir. Next up, we have Dr. Mahesh Gowda, sir, who is going to deliver a session on violence meted out on doctors. Where are we headed? And to chair this session, we have Dr. Srinivas Bhatt, sir. So Dr. Srinivas Bhatt, you, sir, has completed his MBBS from WIMS Ballari in 1998 and MD Psychiatry from Father Muller's Medical College. And he was his professional experience and positions held are displayed on the screen. And currently he is a professor and head of the Department of Psychiatry, K.S. Hegde Medical College, Medical Academy. And he has had 4 international journal publications, 8 national journal publications, and 2 state institutional journal publications. And he has participated in various local, state, national, and international workshops, EMEs, conferences, and talks. And also he has completed 13 clinical trials and has 1 ongoing clinical trial. He is a member of Life Fellow of Indian Psychiatry Society since 2015, Life Member Indian Medical Association, and he is a member of boards and association of the following associations. I hand over the stage to you, sir.
Thank you very much for the, I think you are more than what I am expected to, okay? Dear respected seniors and delegates, thanks for this opportunity to introduce Dr. Mahesh Gowda. He has been my senior colleague, and one thing before introducing everything, he is the person who is grounded, anytime approachable, and any issues we want to take a help in Bangalore, I usually approach Dr. Mahesh. He has done his MBBS from BMC, Bangalore Medical College in 1999, DPM from NIMHANS 2002, and he has and DNB in 2004. And he has the rehabilitation setups. He has started in 2001. He won DLN Murthy Rao Oration Award for Best Outgoing Student, and he is consultant psychiatrist in Spandana, and is the director of Spandana Healthcare, and now he is direct council member of Indian Psychiatry Society, past president IPS Karnataka chapter, and past treasurer Indian Psychiatric Society Karnataka chapter, and honorary past editor Indian Association of Private Psychiatry. He has around 80 publications in Index Journal. This is the very short CV. I can give so many other credentials for him, but for the shortage of time, I'll request Dr. Mahesh to proceed with this presentation.
Thank you, Dr. Srinivas. Good afternoon, everybody. I think a lot of questions were there. Why am I in black, or why are there so many people in black? So protesting violence of doctors is a very important thing. We have all done at our own level. And you've seen a lot of news on violence on doctors, and Calcutta being the ground for all this news. But the protest keeps going on. How many of you here were subjected to some form of violence? Any hands? Verbal, non-verbal, physical? Okay, there are some hands. Okay. Did Dr. Ravish Tunga raise his hand? You also raised the hand, sir? Dr. Madhav. There are very senior practitioners here. I want to understand, sir, were you subjected to any form of physical violence in the last decade? See, they say no. They have been in the field of mental health practicing for the last 4 decades at least, and they have not faced violence at all in the last 10 years. Why do you think it's so important? Are both of them immune to violence? But literature says otherwise. So there is definitely a significant amount of doctors who are subjected to violence, and these numbers can go up to 75%. And in India, the numbers cannot be different compared to the other parts of the world. And at least 12% of the people were subjected to physical form of violence. And I want to understand from the crowd again here, was this violence by the patient? How many hands by the patient? Okay. By the relatives? There are 2 hands from the same person here. From both? Unfortunately, we are the only specialty in medicine where patient also can be violent on us. Most of the time, it's the family members, relatives, caregivers who protest an untoward event of death or something not going well, and the family members are protesting. But here, from the time you're seeing a patient, you authorize admission, most of the time it will be sectioning, casualty, you're working with them. So patient and the family members are the people who can assault a mental health professional. This is a very unique field that we have. We are assaulted from both them. So it's a double whammy. And if you look at most assaults that happen, it happens during inpatient care, particularly in the ICU setups, and sometimes post-op case is what they talked about. And most of the time, it's happened during these situations is what they talk about. But if you look at separate statistic for mental health scenario, I could not look at separate subcategory here. I think whenever we are sectioning, I think this is the problem when you're going to have a lot of violence and because there's a protest. There's some variable literature which talks about 8 to 38% of the health workers suffering physical violence. The first talk was about 12%. So there are some literature which talks about 38% being subject to physical violence. So it is something that we must be concerned about. Coming to causes of violence, there are so many causes that's actually, talked about and it's been debated. Can anyone tell the most common cause of physical violence on a doctor? Death, very good, sir. Anything else? Yes, I think this is the most important thing. There may be a death, but there's still quiet only when you obstruct the body being taken for post-mortem or for the rituals, when you present a bill. That's when a lot of people take the intentions of doctor as financial, and there's a lot of protest, and most of the discontents begin when we present a bill. Things went wrong. If you let them go sometimes, there's actually no fight, there's no protest. But when we ask them to financially clear a bill, which was negative outcome, and they were promised some sort of care, they're discontented, but still we give a bill, they're really angry and upset. So this is what we must anticipate. I think that may come with experience. So if you look at the factors that's generally associated with violence, the policy factors becomes very important. In India, I think if you look at the budget outlay, it's less than 2% is spent on healthcare. A minimum healthcare budget should be 20%. So when you don't have adequate budgetary allocations, imagine the sort of infrastructure you have, sort of services you have, sort of manpower you're going to apply. And we are a huge country with a tremendous population. We really need much more. And the basic discontent and unhappiness could be because of improper budgeting itself, and the policy matter really makes a huge difference. Coming to social factors, the media portrays doctors, healthcare professionals in a particular way, and this is very contagious and people can easily talk about it. Nowadays the social media is so strong, the news reaches every corner of the country, and one doctor being assaulted is shown in poor light. There's no corresponding news that says the person who assaulted a doctor is punished. So what really remains in the memory is doctors can be assaulted and they got away. So this is a sort of social factors and the image that is happening to mental health professionals in particular here, but in general healthcare workers and doctors being pivotal in most of decision-making process, they are the ones who get targeted, and the image is taking a beating here. Coming to professional factors, ideally, if you look at how many patients, an outpatient, can a doctor see in a day? 20. Dr. Ravish would disagree with you. I'm talking Ravish Tunga. So ideally, if you're seeing 20 patients, you can actually give time, you can actually explain a lot of things to the patient, you can do a lot of consenting process, you can do a lot of briefing on the methods that you're using, explain everything to them, document everything, and make sure really safe. And 20 people is a very comfortable number to see. If you look at any UK, US, or American psychiatrist practicing, he says, I saw 2 new cases, I saw 8 to 10 follow-ups in a day, and that's it. That's the whole day, and they spend a lot of time documenting it. So that's why the system is so robust, and you're actually doing everything that's expected. But here in India, you are just the opposite. As practitioners, there are so many of my colleagues who see 100 patients a day. How can you actually do everything that's expected? You're supposed to charge very less, supposed to do a lot of consultation, which will involve history taking, completion, documentation, prescription, explaining side effects, including dystonia, dyskinesia, all those things. It's legally expected and binding on us. But how will you really do this? It's really impossible. And that's where we take a lot of risk, because we are doing much more than what we can. Doctors are really overburdened. And putting these sort of regulations on a doctor to expect them to deliver the best possible care with so much of limitations is a huge challenge which no doctor is able to accomplish. That's why we become vulnerable. So these are the professional factors that makes it difficult for us. Coming to local factors, it may not be so common in a district level place, or it may not be common in a metro city, but there are so many other taluka level places where the politicians, the local gundas, the key important opinion leaders have a big say. If there's a death, they are the ones who come there. It's totally unconnected to them. They're the ones who come and protest. They're the ones who come and get your bills waived off. There'll be some sort of settlement that happens. These sort of local factors are really prevalent, and we must be aware when you're really practicing. So is it really a common practice here in Mangalore? Politicians getting involved with patient care, influential people? Do you have groups of NGOs, patient NGOs who come and say, reduce the bill, they come and protest on deaths? Paid organizations. There are a lot of organizations even in Bangalore. It's unfortunate to say that they have nothing to do with the patient rights or care at all, but they are promptly there at every other adverse event that happens in hospital. They all come with a towel. The color of the towel could be variable depending on the organization, but the agenda is very simple. They want to make sure the doctor pays for it. And they're the ones who negotiate with police, and police are, together with them. The moment there's adverse events, they'll say that, this organization is calling us and contacting us to know what's happening. So police inform them, they inform police, and finally patient is clueless why these people came. But they actually land in the situation when there's adversity. They are there for bargaining. So why is this sort of violence generally happening? So the basic fundamental thing here is there's a lack of trust. Why did this happen? There's multiple factors. We have evolved from a time when we were treated equivalent to gods, and we could make a lot of decisions. It was Guru-Chela relationship earlier, and we knew everything. We could make decisions, and they were expected to just follow. And we moved to a stage when it's a patient who's making all the decisions. You may provide the information to the patient. The family and the patient should have a right to do what they want, and we are just the providers and facilitators here. We cannot make any decisions without informing them and taking their consent for the whole process. So, in terms of billing, when we admit them, we would have given a particular number on the billing process. At the time of discharge, it's sometimes 2x, 3x, 5x the times, and you don't know, there's so many other variables that come in. The patient and the family in for a surprise. So they feel that doctors cannot be trusted. We are doing investigations, sometimes over-investigating. And if you look at the most commonly abused investigation in psychiatry is EEG. I must admit that there are so many people who do EEG, it's totally unconnected to diagnosis management in psychiatry, but it's actually happening. So patients have lost trust on us for various reasons, and they think that doctors are here to exploit us. It may be few doctors in the entire community who do it, but the image of doctors takes a beating, and the media, social media, the news, print media, all those people portray doctors in poor light. We also don't have support from the community. If there's adversity, the patient NGOs come in very promptly to the hospital. But if I have an adversity, I cannot call anybody. Whom will I call? There's no communities who are willing to lend their name for a fight with a doctor here. So we are totally helpless. We are on our own. So there's no support system for our community unless we really plan and gather all these things. Our staff is not actually trained in soft skills. We must admit that, all our UG, PG curriculum never address the soft skills. Is there any class in the current curriculum that talks about interviewing patients with soft skills, communicating, diagnosis? Has somebody taught you how to communicate death to a family member? New syllabus, but when you all graduated from MBBS, did you have all this training? We all graduated at a time when all these things were non-existent. This is becoming imperative for NMC to make this as an important part of the curriculum now. And if you look at whatever I learned in psychiatry, the sort of interviewing skills and MSc and all this diagnosis, if you look at the typical format, it takes 45 minutes to 1 hour to evaluate a patient and treat them. Right now, I'm treating a patient every third or fourth minute. Who trained you in all these things? There's no curriculum, but we are really doing it. How did we really learn it? So we are compromising all these things somehow, because typical training is different. We're actually practicing something that's different. And if you look at what MSc has done, it's actually discounted so many things that we are actually doing. We're capturing so many things of the past history, family history. It's totally irrelevant. What is needed for the patient is all that we must document. 6 to 8 headings for the OPD patients, 15 headings for the inpatients, and all the other part of history that you collect from the patients is totally not required, because you're expected to maintain records and do the diagnosis in an algorithm that they expect. And this does not look at so many things that we're actually doing. And soft skills, it's just not you. The support staff, your other allied professionals who work with you, psychologists, social workers, it could be nursing staff, the front desk people, all of them have to talk the same language. Do all of them have the same soft skills? No. And the process and systems are archaic and cumbersome. So if you look at what really worked 30 years back, 40 years back, the system is running and it is actually not relevant to do all the things that currently we are expected to do, but it is running. We don't make an attempt to review all the system and make a change. So that's why a lot of potential for violence. Paying bills, I talked about it. Most of the time, they expect discounts, good outcome or bad outcome. At death, they definitely don't want a bill. So we must somehow have in our mind to let go sometimes, because we can definitely earn this money back. If there's a bad outcome, and if you anticipate that there's going to be trouble, try and refrain from issuing bills for them. And there's no deterrence for violence. Yes, there are laws, but how many patients or family members have been punished for violating doctors? Assaulting doctor, there were so many instances, right? Tell me one instance where actually doctors who were assaulted actually put a case and actually finally won the case and the family member got punished and imprisoned. In Karnataka, there's only one case where the family member was imprisoned for 1 year. Is this the order? It is challenged again. Okay, so in conviction rates, we have nothing to say. Dr. Badamat explained why doctors don't complain. So if I complain, the police will teach them to give a counter complaint. They will draft the complaint in such a way that we are into trouble. So they all gang up to make sure doctor actually takes the back foot. And that's a problem in the system. And when we're talking about policy factors here, if you look at mental health as a scenario, almost every other person is paying the bills of treatment from out of the pocket expenses. Insurance hardly reimburses. The current directive from the government, IRD, all those things is making mandatory for them to do it. Currently what I've been told is they're reimbursing up to 50,000 rupees of the bill. There's a waiting period or lock-in period up to 4 years. And they're not reimbursing teleconsults, they're not reimbursing outpatient practice, they're not reimbursing suicide attempts, they're not reimbursing substance abuse, but all these exclusions cannot exist. In paper, it is there, but the fact is that most of my clients who have been getting reimbursements only up to 50,000. Yes, there are 1 or 2 scenarios where they've gone to the ombudsman and they've made some orders and they've got the complete reimbursement, but it's a very cumbersome process. And if you look at the causes here, There's so much of patient load in a government hospital, adequate manpower not being there, new infrastructure not being introduced there, that makes it very difficult for them to work in such an environment. Doctors are portrayed as bad, but the infrastructure is also not supporting for him to deliver anything better. And what happens to other scenario? The complete corporate, very nice setups. Is violence common in these sort of setups? So who believes only violence will happen in government setups? So violence is common and higher rate is established in all the studies in government setups. The least that is there is in corporate setups. Well, what will happen to middle players like us? So here there's two set of patients who can afford go to the corporate setup. They get good care, they're happy. Outcome may be negative, but they're good consenting process. They're seeing less patients. So they pay hefty bills. At the same time, they accept also, and the violence is lesser. On the other hand, they don't pay anything to the government hospitals, but they expect a lot of facilities there. It's not happening. So there's a discontent and violence is more there. So in between, if you look at, one person is getting services at no cost, other person is getting services at highest cost. So there's another important sector of people, which is the majority here, out of the pocket expenditures from the patients and family members who want good service. They don't want government services. At the same time, they cannot afford the corporate services. They go to the other private practitioners and hospitals. They're expecting, again, very good service. They believe that if they spend more, the outcomes will be good. And every bit of money that they're spending comes with hard effort. They're taking loans, they're selling properties, they're pawning, jewels, and they mobilize this sort of money to expect good outcome. And most of the time, depending on the cases, negative outcomes is very common. So there's no rule that no patient should die in a hospital. Death could be eventuality in so many cases, which they don't accept. And profit making for a few in the profession has led to image beating, and that leads to a lot of discontent. Patients and family can have unrealistic expectations. Unless we address this, I think we are into trouble. We lack effective patient-doctor communication and relationship. It's possible, rapport is the very important thing, but we don't have time. How will you have an instant rapport in 3 minutes, finalize a prescription, and actually ask him to leave your cubicle in another 1 minute? So all that you have is 3 to 5 minutes. How can you really effectively do it? I think it's very difficult and challenging. Very few have accomplished it. And people who are able to have good doctor-patient relationship are actually immune from litigations in the earlier times. But here, every other patient can be a potential litigant. He may be happy with you today, but when his psychopathology goes haywire and he's symptomatic, he can actually initiate a litigation. So even that is not an important factor current scenario. Mob mentality. There's no logic, no reasoning that works with a mob. You may be the most effective communicator, but when you're handling a mob, you really don't know what is going to work with them. Most of the time, you being in the forefront is very difficult. You must always mobilize some colleagues who can be in the forefront. You can always give clarification, but you should not be the person who's trying to pacify the mob there. Lack of security. We spend very little on security. We don't have bouncers. A typical scenario should be that, hospital should have bouncer who actually does some round of rounds, talk to family members, talk to patients sometimes, does his own round, just to say that there's a system in place. We don't spend money on all the systems, and that makes it vulnerable for people to get into violence. And most of the time, if you look at the violence, they target the younger doctors, because these are the people who work in frontline. There are people handling casualty. There are people doing admission. I may write an order, injection, admission, sectioning. I'm doing all those things. But one of my colleagues is anchoring that, and he becomes vulnerable to most of these sort of targets. And the mob patients generally target younger doctors. It does not mean the older you get, you're immune. But most common violence is in the earlier days of our career. We could be inexperienced. We may not be able to communicate effectively. Our judgments, skills on a potential litigant, a potential violent patient member or a family is something that we don't have a way of assessing it, and that makes it vulnerable for us. I just picked up some news here. So we had Dr. Vandana who got stabbed multiple times by a patient whom she never knew. He came to casualty. The patient was literate. He's a teacher, is what I was told, and without any provocation. So where is there a system of evaluation? He picked up the scissor from the tray there and actually stabbed her multiple times. So it's a professional hazard, sometimes you become vulnerable. Tripura, a doctor attacked by youths at hospital in Agartala, the medical community expresses concern. So every time there is a news like this, we express concern, we do protests, but nothing seems to really change. And another instance where the doctor was attacked, and here there's a nurse who was attacked with iron rod in a government hospital setting in Andhra Pradesh, and they staged a protest, and patient has been detained by the police. After that, no follow-up on what happened to the person who protested. Do people here think that only doctors are subjected to violence? Who else could be subject to violence? And patient bystanders. Any other profession who is also prone for getting into violence? Police, yes. Police are the people who actually violate so many times the rights of a common man, forget a person with mental illness. So we are being branded as violators of patient rights during admission process as psychiatrists, but every other day there's so many instances where the rights of a normal person is not respected. How many of you here are comfortable to walk into a police station for a complaint? I don't see any hands here. I'm a normal person, I know my rights, I know that Constitution is there to protect me, and I'm a literate person. I just have to complain on somebody else who violated my rights or some other mistake. So I don't have the courage to walk into a police station. This is the sort of confidence a common man has. So look at the scenario with an educated population like doctors here. All other professionals who are dealing with public, it could be government servant, bureaucrats, police, it could be lawyers, or anybody who's dealing with public are prone to get into this sort of violence from the people that they deal with. So this has been the news. Does anybody here know exactly who's the culprit and what happened in this case? We heard so many versions to the whole thing. We heard, the media for close to 3 weeks now. I really cannot make sense actually who is the perpetrator here, what exactly happened to doctor. I really don't have any news. I just know that, there was an angry mob who destroyed the hospital. A doctor is affected here and they're trying to raise protest on that. But the angry mob destroys the hospital. I couldn't understand where the logic was. And there's so many hypotheses here, I really don't know what really happened in this. And media is really helping us to clarify our doubts. I don't think it really got clarified. And yes, politicians can add some sort of color, the changes can happen, and the versions can change. Another important question is, do doctors need a Central Protection Act? Because health is a state subject, and it's there in the 7th schedule, and it's a part of the state to run the state services, because it's important that each state takes this sort of responsibility. It's not there in the concurrent list. Central does not have any say here, so it's a state subject. So why do we need a Central Protection Act? IM has been fighting, doctors have been fighting. We want a Central Protection Act is what they say. So the key factor here is government is considering to have a Central Protection Act, but will the actual ground scenario change even if you have a Central Protection Act? There are at least 19 states which has some form of acts trying to protect healthcare providers and professionals here. Having Central Act may not really change unless there's a change at the level of law enforcement agency, judiciary, and the sorts of trial that happens. There should be quick resolution. Somebody assaulted, there has to be a sequence to it, and he should get punished, and that must be portrayed in media. Unless that happens, this sort of image beating that doctor has and this violence will really not stop. We had a president who came to the rescue who talked about concerns on healthcare providers being assaulted, and this sort of prohibiting violence against doctors and healthcare professionals. She talked about a separate legislation and some sort of need for change. So government may consider making a central legislation now. As on 2019, there were 19 states with an act there to protect healthcare providers from violence, and this is as good as being on the paper because nothing has changed. If you look at the statistics, there were 6 to 7 cases where they were convicted for violating a healthcare provider pan-India. And this act is supposed to be there in 19 states. So hardly any complaints, hardly any actions for that. In 2020 September, when there's a pandemic, government suddenly realized that there's a need to protect doctors. So quickly they got in an ordinance, and following the amendment to the Epidemics Act here, they defined what an act of violence could be. It could be even harassment, which is impacting the living conditions of people providing care there, intimidation, and the punishment was 3 months to 7 years, fine up to 5 lakhs, and all this thing was good. And since this was a cognizable offense and non-bailable, they thought it could be a deterrent for people who are trying to be violent on them. And the best part about it is there is a presumption of an offense being committed unless the contrary is being proved. So a doctor did not prove that an offense is committed. Once you complain under this modified version of this act here, there is an assumption that the crime is already been committed. And the new law came only to effect during pandemic. It was an ordinance, so very conveniently 6 months every ordinance lapse. It's never renewed, and they gave the best possible care to the patient, but the doctors lost the advantage that they had 6 months later. There's also a bill that was promoted in 2019. It was revisited in 2022, where they felt that they wanted to have a separate central law for prevention of violence against healthcare professionals and clinical establishment bill. So in this, they've actually explained that this is going to be a cognizable offense. When you say cognizable, the investigating police officer can arrest a person, can file an FIR, and do the trial without actually investigate the person without actually needing any official permissions from a judicial thing. So it is cognizable and non-bailable because he can be arrested, and only they have to seek judicial intervention to take a bail there. So whoever actually attempts to commit violence shall be punished with imprisonment, which may not be less than 6 months, which can go up to 5 years, and with the fine which can go up to 5 lakhs is what is being proposed in this bill, similar to what was the modification in the Epidemics Act modification that they had. Suppose one of the healthcare professional has grievous injury here, the minimum punishment will be not less than 3 years. And it can go up to 10 years, and the amount of fine will be a minimum of 2 lakhs, it can go up to 10 lakhs is what is being told, and it can be a significant deterrent if this is actually put to practice. Suppose the family member or a patient has destroyed furniture and hospital premises, so there's a means of mechanisms where 2 times the amount can be recovered for damaged property, and if he does not have the money, they can actually attach his assets by way of recovery by the DC. It's through the Areas of Land Revenue Act, and there they can actually move to recover this sort of costs from the patient and family members. So this sort of provision can become a huge deterrent. It does not come easy. The law also expects us to follow so many things that we should not have a long waiting system for the patient. We should not make it too cumbersome for the patient to go and do a lot of paperwork, do a lot of running around. We should make it easy for them. We should give all the information that is medically available through the guidelines. And we should also give them an option for second opinion. There should be no information asymmetry. There should be a system of grievance redressal system. Hospital security has to be improved. Transparency in consultation and the costs have to be done. And we have to report issues of violence on healthcare professionals periodically. We must display the constraints under which we work. We did it during COVID. After that, we also forgotten. The constraints could be waiting time. The constraints could be manpower crunch. All those things could be displayed actually in case there's anything like that. We also have to revisit the curriculum of medical education is what has been proposed and expected from us. I think Kerala was in the forefront because with all the provisions that they had, their modified act that was done in 2023 actually made sure that it was the best act in terms of trial and punishments. And that was considered the strongest state law in India trying to protect the healthcare professionals. So with this, it also covered wide range of healthcare professionals, nurses, technicians, clerks, ministerial staff, security guards, whoever is working, everybody was covered with this sort of act. And it makes it a cognizable, non-mailable offense again. And violence against healthcare workers has been taken as a prime issue there, and they've defined exactly what amounts to violence. So I think Kerala was in forefront. And if you look at the Karnataka scenario, Dr. Badaman talked about this act that we have in our state. So it is the Karnataka Prohibition of Violence Against Medicare Service Personnel and Damage to Property and Institution Act, which is an old one, 15 years old, 2009. And here they have section 3, which talks about violence. And whenever there's a violence on a healthcare provider, so there's a penalty which is cash and also in terms of imprisonment. It can be up to 3 years with fine, which can go up to 50,000 rupees is what was mentioned, which was way back in 2009. That was a significant amount. It's not enough. 50,000 seems very petty now in the current scenario. And again, it is cognizable and non-bailable is what it talks about. We have a modified version with a new health minister, Mr. Dinesh Gundurao, who actually made this modification. He made very similar to Kerala Act, and they say it's even more potent because it seemed to have blocked certain loopholes for patient or the family members escaping. If you look at what is there, most of the defenses that the patient or family member uses, they say all this happened in the spur of the moment. I'm in grief, I've lost a family member, I was enraged, this happened, that happened. And so many times they can give in a lot of complaints which looks reasonable for them to follow. The spur of the moment is actually used by a lot of things and sometimes it's sustained. And court looks at this seriously and they've actually let this sort of people go because they said that I had no control. It was just a rage, the spur of the moment. But the current modifications, I'm not aware. Dr. Padamat spoke about it and he said that BNS does not have this sort of provisions. But I was talking to a legal person who actually was a witness to a lot of procedures that's happening. He says the patient's family members use this, that everything was in a spur of a moment. And the law enforcement agency, judiciary looks at this as a sympathetic way because they think that they've lost a family member, they need some sort of consideration. And both Karnataka and Kerala seem to be in the forefront and they seem to be creating a very robust legal protection for people working in these states here. And even the center seems to be not far behind. They have a law that they're trying to make. The bill was presented in 2019, 2022. With the Calcutta incident, they're actually trying to revisit this and see what exactly they could do. All that we can do is keep protesting, getting attention to make sure that we get some sort of changes in the system to add confidence for people to work in situations fearlessly. It has also caught the attention of the Supreme Court here because the CJI talked about issues like extremely saddened to witness the rising violence against doctors. And he also hinted on revisiting the need for having central legislation. There's also a move to make sure that the institutional head files an FIR within 6 hours after coming to know about an incident, and this is the time limit given. The police also have a time limit to make sure they spring into action whenever there's a complaint like this. Dr. Padamat talked about this. If you talked about violence, harassment, intimidation that really happens, this happens more with the law enforcement agency itself. The best thing that they use is they use 304A to say that there was actually injury caused by a person with medical negligence, and this is amounting not amounting to death, but this is rash and negligent act is what they say. And the corresponding section of 106 is also not exempted us. So if you are a registered medical practitioner, it is 2 years instead of the usual 5 years. That's the only concession that you have, and you will have imprisonment and fine here. It is not either or. So a lot of discussions are happening on this, that Section 106 has decriminalized doctors and you cannot be prosecuted under sections. But I think the clarity is that you are still vulnerable. You can be prosecuted for rash and negligent act under Section 106. And we are bound to get in trouble with this sort of scenario because police have an understanding. They're going to use this sort of scenarios to target doctors and medical practitioners because there are so many times when family members complain and they are emotional. The police add fuel and they give this sort of relevant sections and explanations so that you're covered, and they target doctors by way of arrest. And suppose what happens, if you look at the conviction rate, it's also very small. If there are 100 cases filed by a police against any citizen of this country, the conviction rate is less than 2%. So 98% of the time they get acquitted. So also it's a doctor, he may get acquitted, but what's going to happen to him? He has to seek bail, he has to abscond. Till he gets bail, he cannot be seen, and it's a lot of embarrassment and harassment by the whole system, and you cannot really practice. And this is very stigmatizing because these laws can be used against doctors itself. And how do you actually solve this sort of crisis? CCTV footage is very important. The fact that you mentioned that you are under surveillance, the CCTV footage and things like that will make them alert for actually presenting some sort of corporate behavior. May not be all the time, but most of the time it is helpful. Documentation of a detailed consent, audio-visual consent is what most surgeons do. But as psychiatrists, does anybody follow here audio-visual consenting? See, because we don't have procedure, we don't understand the need to document, and we just take a signature on a form, which court looks at this as pre-filled form and has less importance compared to a detailed audio-visual documentation of a consenting process. Suppose you would consent, there's an expectation that you must upload it to Google Drive so that it should be preserved. Sometimes family members destroy records. They take away records, they tear it up and things like that. You don't have anything to prove that you've done the consenting process. So they expect you to put it on Google Drive and upload it also. We have to have good training and SOPs. I think it's an endless thing. If you look at NABH accreditation, so they all stress the importance of having SOPs to manage a difficult patient, violence, suicide attempts, everything can be a part of protocol. Training them. Adequate indemnity cover is very important. In the current scenario, the court had awarded 12 crores for that Calcutta case. So my proposal was for 5 crores. But as physicians and as psychiatrists, this coverage seems adequate. So having one cover of 5 crores seems adequate is what I think. But if somebody wants more, you can apply more. Suppose violence happens, what do you really do? On the ground zero level, when you're actually subjected to violence, it's very difficult because you don't know. How many of you here are trained? Does your hospital where you work train you to handle this sort of code purple and code red and say that how to handle a person who is violent? How many of you here are trained on handling violence? But we are dealing with these patients, we can have violence any time, but we don't have training practices at all. So there has to be good, robust training system, and you must have SOPs, you must have regular mock drills. If a patient is violent, how to manage it. Unless you have this sort of systems in place, very difficult. Avoiding direct confrontation. If the patient is unhappy with me, there must be one more colleague who becomes the forefront and he actually has to deal with him. Answering him back, trying to give a lot of clarification, sometimes is not looked at in good spirit, so it becomes difficult. So somebody else should do the clarification. Remaining calm generally helps. I've seen a lot of senior practitioners who are just calm in this sort of crisis. Most of the time, they just give an active listening, very few clarifications. Non-confrontational approach has really helped them solve crisis. We should not react, but we should respond with authority when it's needed. The moment we keep reacting and trying to answer every other thing, it may not be really prudent. They can keep ventilating, they can keep saying what they want, but only respond when it's needed and don't react to everything that has been told. Preserving medical records is very important. Having authorities on call. You must have a system of networking where you have a good friend in a police department, a good friend who's in the legal fraternity, a local influential person, somebody from IMA. Somebody should be on call. This is like a phone a friend. You must develop this sort of network, and this network is really net worth for you. You must have these sort of practices and have these sort of connections. They should be the one who should be contacted. If you cannot do it because you're the frontline person there dealing with the crisis, your support staff should be encouraged to call them and they should come for your rescue. And preparing yourself. We all sometimes get into a negative mindset, like, doctors are always harassed, doctors are always targeted. I don't want my kids to take up medicine again. So we have our ingrained biases now. I think we must try and fight. We feel we are vulnerable. We feel we are victims. I think we should also reach a stage when we feel we are victorious. We must assert ourselves and say that we are in control of the situation, just to make sure we have some sort of energy to work in this sort of difficult scenarios, and we have some sort of courage to actually see patients. Otherwise, we are going to be extremely defensive. We may not take up any sort of difficult cases. We may not deal with emergencies. Sometimes it's bad for patient outcomes also. There's huge responsibility on government. We talked about budgeting. There's a lot of responsibilities on media here. I don't have to deliberate on this topic simply because we know what the media should do for a person who's working in a healthcare system with so much of limitations, huge liabilities that comes on us. And sometimes they get in concept of diagnosis, symptoms, management, treatment, add multiple confusions to a current scenario. They show doctor in poor light. All these things could be really avoided. From doctors, I think we must not do things that can put us into a state of vulnerability. So do not overreach. There's some sort of limitation that each one of us can have. So let's treat somebody whom we can, and let's not try to treat everybody. So we should not treat beyond the scope of our training and facilities. So if my specialty and training allows me to have an expertise to treat certain thing, we should confine ourselves to expertise only. And if you don't have facilities, we should not want ourselves to treat such patients, refer them to a colleague who has better facilities. Valid and informed consent is absolutely essential. Effective communication becomes important. Responsibility of institution. So NABH training, having SOPs, protocols, having code purpose. If somebody presses a button, all your staff except the emergency and ICU people who are working, including office staff, everybody should be there at the crisis. It is basically show of strength. So if there are 5 family members who are protesting, if you have 50 staff who are there, that is the best way to settle certain issues. If you have good security system with 3 or 4 guys who well built, who are like bouncers, their presence itself can be a deterrent for the family to become violent and actually destroy something in hospital. So it's the only time that you have, it's the ground zero time. At this point of time, we should make sure you mobilize everybody. Alerting everybody on a case of violence should be very quick. Security should respond immediately and assist whenever that's needed. De-escalation of the situation should be done by a senior member. In your team who is senior, generally he is believed to have some sort of wisdom, calmness, and sort of receptive skills which will really come handy. We should practice restraint and not lose control in this situation because something has really gone wrong. He could be, unhappy about the cleanliness of hospital, the toilet, hygiene. It could be about the behavior of a frontline staff. Actually, this could be a genuine problem. Unless we really make an attempt to address it, I think we're going to frustrate matters. We should have mock drills. Looking for symptoms and something that could predict violence is something that we must keep in mind. Somebody who's staring, somebody who's mumbling, muttering, aimlessly walking, pacing, the tone, if it is raised and if it's in a mood to fight, these are people who can create problem for you. So just be vigilant, taking a step back, trying to address whatever they want, and whatever the things could be really addressed can really come handy. We talked about the Rajasthan doctor who actually hung herself because she was booked on a 304A for rash and negligent act. So this is the first time, a doctor was subjected in these sort of scenarios, not having adequate knowledge about their own rights. Having an FIR and being framed under this does not mean that you'll get prosecuted. Has anybody here been subjected to 304A? Anybody who had complained in medical council? Anybody who had complained in consumer related claims? Okay. So if you have chosen the profession, you're bound to get into some sort of discontent, and discontent is very common because you cannot give 100% cure with patients. You cannot give good outcomes for every patient. So there's going to be discontent. You have to find ways and means of dealing with it. So having a case does not mean that you're a criminal. So that's what I learned first. Getting court notice does not brand me as a criminal. Just because somebody raises an FIR, looking at statistics, it says that 98% of the FIR are false. It's going to be not proved. So I believe that I'll be among 98%. So my case of 304A was about a patient who actually tried to escape from the hospital, squeezed through the grill of a third floor window. She tried to get down, she fell down, she died. She died in a hospital, some other hospital, 1 week later. So I was booked under rash and negligent act leading to death. I never pushed the patient. I never asked her to escape. I had no control because the architect had designed this grill, which was good enough for nobody to escape through a window. It had a grill system. So somehow she had flexible joints, very thin built person, and had everything captured on a CCTV image. I had everything with me, but you are framed. And I took close to 5 years to get it squashed with the High Court to say that this is an improper FIR, and the court felt that this is not appropriate, and they actually squashed it. My passport was not renewed for 3 years. So this is the harassment I went through actually. So what does it mean when a doctor actually becomes targeted to violence? So it is very distressing. Just getting a court notice, a lot of doctors panic. One bad ECT, people give up ECT practice. So a lot of feelings of shame, guilt, low self-esteem, stress, depression, anxiety, wanting to kill themselves, cursing why they took up psychiatry. All these things are also common. I had a very senior teacher of mine who had worked in a teaching institute, and when I was talking to him, he said his biggest regrets of his life was taking up psychiatry. After actually having finished his career, extremely soft person, the best person with good soft skills, he said, patient really never appreciated my sort of efforts. They didn't appreciate my dedication, and he felt that he did not get the required sort of reciprocation from the family, in spite of patient's family I'm talking about. In spite of all the difficulties and hassles that he had taken, he never felt rewarded in terms of reciprocation. This is the guilt of a person who practiced for 40 years. Just because there are court notice, there's some sort of complaints from the patient's family, it can really ruin your self-esteem and your decision-making abilities. It can reduce your job satisfaction, self-confidence. It can make you extremely defensive. All difficult cases will be referred out. You'll never take up a decision to admit them, and defensive practice will lead to poor outcomes and higher costs also. They may sometimes change the location of work. They will leave the country and go somewhere. So it is really bad. Even though nothing is happening, you're not convicted, just a simple violence and complaints to the police can really deter a doctor from taking a lot of good decisions. The NMC has come up with rights. For the first time, the new gazette that they actually did, which actually is right now under suspension. So this actually talks about rights of a doctor. So if you're not comfortable to see a patient, you have every right to refuse a patient, except in terms of emergency. For the first time, NMC says that by virtue of your professional choice that you've done, you can actually refuse a patient if you're not comfortable. You can identify unruly patients, you can identify difficult families and say you don't want to see them. So going forward, I think Indian government should implement the recently passed ordinance that was like the Epidemics Act, right? So that seems to be giving a lot of teeth to law enforcement agency. I think we must move towards getting such good laws in center. Government hospital needs a lot of rework. All doctors should be made aware that violence prevention policies at the workplace is extremely important. Doctors have rights, patients have rights, and these are non-negotiable. They cannot violate our rights and we should not violate their rights. Only under special provisions we are allowed to violate the rights with adequate documentation. Hospitals should take appropriate action in case of violence. It is the whole system that needs to come in. One doctor cannot fight a simple act of threat and violence. So I need to conclude here by talking about what Dr. Robert Owen has talked about. Very important saying here, gods and doctors are alike adore, but when in danger, not before. The danger of over both are alike required. God is forgotten, but the doctor gets slighted. So we are like gods, but when it comes to a negative outcome, gods are not to be blamed. They don't drag gods here. It's the doctors who gets blamed here. And I thought I took more than what time was allotted to me. And these are very common pictures that you get it on the internet. All the slides that I've, materials that I've collected, it's all available on net. I've left it with the organizers also. And violence is common. It must not deter ourselves from choosing a medical profession. We should not deter our kids from taking medical profession. Helping them understand the limitation and working with the limitations and making sure we make some sort of corrections to reduce this sort of outcomes is something that we can talk about. Thank you so much.
Time for the questions and clarifications.
Sir, thank you for the good presentation, sir. Sir, I have one doubt. When somebody assaults somebody in an airline, they are grounded for 6 months. They can't fly in any airline. So that is a true deterrent. They will not assault anybody in their life, in the airplane, anytime in their lifetime, if they have a proper IQ. Why can't we doctors ask for such things for patients? We don't want them to be punished, put under 2 years penalty. We don't want their money. But can we do something like they will not be given any medical services for the next 6 months if they are proven to have assaulted a doctor? Can IMA or organizations take up this kind of deterrence? If they can do it to an airline, why not for doctors?
I think it's a very valid point, Aruna. If you look at the case that Dr. Suresh talked about, Jacob Matthews' case there, they had laid down certain guidelines for how they should work with the case of Rash and Negligent Act, and they put in guidelines and said that this is temporary, and NMC should come up with a guideline which is going to work on how a doctor should be evaluated whenever there's a issue of complaint against doctor for Rash and Negligent Act. This happened more than 15 years back, or I think 18 years back, but still now NMC has not, it is in their own portfolio that they can say how a doctor should be evaluated whenever there's a complaint. They've still not done it. When you're talking about this sort of, grounding deterrence for patients who are violent and things like that, it is definitely possible. I think NMC has a major role here in terms of policy making here. IMA and all this organization, IPS also should join here. But somehow the patients, the sympathy profile is much stronger. The lobby of patient rights is much stronger than doctor rights. If you look at what's happened in MHCA, by just violating a patient's right and forcefully admitting him under the legal provision of 89, and if they prove that I did a wrongful detention, I have the same parameters of deterrence, like imprisonment, fine, when it comes to violating by a patient and assaulting me. So patient, if he assaults me, I get a complaint, I get a deterrent of 2 years imprisonment and things like that. Whereas I just violate a patient's rights by admitting and it is proved false for whatever reason. The understanding of the judge could be different, but the complaints and punishments are similar. Me trying to make an attempt to treat a patient and it goes wrong with no other intention except that the patient's good will and his outcome was kept in mind. So the law making agencies and the lobbying is so strong for patients that they will get more attention and doctors will not get this sort of attention. Most politicians don't think that doctors are a vote bank. They will not fight for our cause. Recently somebody was asking that, with the Calcutta incident, very same college has produced a psychiatrist. The psychiatrist is an MP in the current government now. She did not give a statement. So, though they're doctors, they've understood the whole situation. Being in the seat of being a policymaker, somehow this does not get the required momentum to make a change in the system. I really don't know how to fix it, but I think a change is definitely needed. We must all work for it.
One more doubt, sir. If you told of at the spur moment, like that is used as a defense. Suppose somebody slaps me. I slap them back. The doctor gets really angry that how can you slap me? And I slap him back. Am I liable to be punished for that? I too can tell that it happened in the spur of a moment. He got me angry, I slapped him back.
In the Indian Evidence Act, this is used as a defense and it's applicable to all of us, whether it's the patient, doctor, anybody here. The spur of the moment clause, what they use, is applicable to everybody. By the way, anybody here has assaulted a patient?
Sir, then doesn't it make sense that in the code violence, if the perpetrator has assaulted the doctor, they have a team of people who will assault the perpetrator also back, beat him up nicely. The punishment is meted out there itself. So it should be made legal, no, sir?
But if you ask me as an activist, yes, I want decision to happen instantly, the way they did in that encounter. Police encountered, 2 or 3 rapists of a dentist, I think, I forgot the scenario, where they felt that, justice can only be derived by executing them, and actually shot them and actually killed these people because the trial process is 10 years. The very intelligent criminal lawyer can actually look at the FIR report, look at the complaint, and look at the charges and diseases framed and find so many loopholes and get away from the system. So when I'm saying conviction rate is only 2%, an intelligent lawyer, if I can afford an intelligent lawyer, I can get away from a system. So the judiciary also believes in really punishing somebody who's actually done a crime, and benefit of doubt, if they feel that he's innocent, they'll let go. So I think I would also believe in what you're saying. You must settle score then and there in a very acceptable way. You have CCTV coverage. If they're going to coverage you doctor beating up a patient, it's going to be huge news. I'm going to be there all over and I'm going to be
ported. Won't it act like a deterrent is what I'm telling. If you beat a doctor, the doctor is going to beat you back. won't it act as a deterrent? Now they are getting away because they know that doctors are too polite to beat back.
Yeah, how many of you actually give a threat back to patients? Recently, a patient who's acutely symptomatic on a background of F20 illness, he actually looked at me, that is, I'm talking about just 5 days back, okay? He looked at me straight in the eye and said that, I'm telling you for your good, okay? You better discharge me, otherwise you don't know what consequence I will do. Okay, he is actually threatening and challenging me. Ideal self is like, as a doctor, I'm supposed to say this is psychopathology, not react on it, not respond to it, ignore it, just mobilize resource, just sedate him. That's my typical scene. But the inherent, personality traits will make you respond to it. And reacting is bad. We must respond and give them a strong message that you're not going to take low. And say that, you're going to take steps to make sure he's punished in whatever way. In a very nice way, you should also communicate that you're going to beat him up also, even if you don't beat him up.
Thank you.
It will act as a deterrent. Having just strong bouncers really is a good deterrent. That is show of power. When I talked about important factors, networking is a very important factor. Taking care of patients in a very good way as per the protocols becomes second most important factor. Third one is show off your strength also. How does your system really show that you are powerful, you are geared up to take care of any crisis and any violence that happens? This show of strength, that's also equally important. You must have a powerful system also. Yes, Ravish?
No, this is answer to one of Dr. Aruna's question. Like, can the patient be banned by seeing by other doctors? This is impossible to do. With the constitutional right what the patient has, okay, because right to health is a constitutional right. Even the prisoners who are convicted, who are for the capital punishment, have to have the right to get the help. So that is impossible because flying is a privilege. It's
but
not a
NMC allows blacklisting, right? If you don't want to see a difficult patient family, it allows you to blacklist them and say that you will not see them, except in emergencies.
Yeah, that is only for the particular doctor.
Doctor and institutions,
yes, that's all. But for government institutions, they can always utilize the government services.
Yes, Dr. Poonam has a question.
This is something similar to what Dr. Aruna was discussing. Somebody files an FIR against the doctor and it is proven false. The doctor has undergone so much trauma and so many years of difficult time. So is there any repercussion on the patient who has filed a wrong case? Is there any provision so that they also get punished for not?
See, there is something you can claim damages here, that there is a civil compensation that you can claim here. Ask for defamation case. How many of you here have actually attempted defamation case? See, there is provision here to claim, but I had put a defamation case on somebody. I had no energy to pursue it. I let go. I had spent enough money on the lawyer also. I had pursued this case for some time, but it's such a tedious process. I let go because he had complained on me with prima facie evidence to say that I had given a false certificate to a patient, and he wrote up a 10-page complaint to the KMC and said that I had given a false complaint, and he made direct allegations. He had nothing to prove. So KMC had overruled all those things and said that I was in the right and had done everything correctly. So I had something in my favor. That was a very good grounds for defamation and to prove that. But I had no strength and time, resources to really pursue this matter. I could only complain. After that I let go. I couldn't follow up. So we must use these sort of provisions because this will act as deterrent again. If that comes in media that, doctor claimed damages and he was awarded 10 lakh compensation, it's a big thing. This is all there, but we don't use it because most of the time when it's a complaint from a patient's family, the police know that they can get money only from the doctor because the aggrieved patient's family will not give them any money. And when I want to complain on the doctor, Dr. Suresh also mentioned, they will ask the family to give a counter complaint which can be more stronger than mine with so many provisions. They may bring in caste issues, they may bring in discrimination issues, they may bring in abuse issues for whatever reason, and make so many charges. And finally, the police wants no headache, they want settlement here. They want their bucks here. The patient family may get some money, the NGO that comes to rescue will definitely get money. Finally, the sufferer is the doctor here. The patient may not get money at all. Other people really in the system share the money. Police definitely want their cuts here, and the NGOs want the cut here.
Another question. if mentally ill patient with the poor capacity, he destroys the hospital property and will he be liable for, they have to pay the damages or?
There are no special laws for patients for anything like that. Everybody is liable for their act here, unless and otherwise there's a diminished responsibility for way of, the assessments and court intervention to say that he had diminished responsibility for a crime. If that does not happen, everybody is liable. So it is a separate suit. I can just give an example that, a patient did not destroy anything in the hospital. He just refused to pay my bills. My bills were raised to an extent of 40,000-50,000. He refused to pay my bills. So there is an injury. I can prove everything that he had signed up the consent and all those things. So how do I recover this money? So I have to hire a lawyer. I have to, try a civil suit here asking for claim of this money. I don't even have a check that gets dishonored. If I have a check as an instrument which is dishonored, I can at least claim that he did not honor the commitment. He has just not paid the bill. The procedure for me to get 30,000 rupees, which is the pending money, will make me spend at least 50 to 60,000 rupees money to get this 30,000 rupees money. It's really not worth it. So there is system in place, but it's no easy way out. All litigation, civil matter goes on for so many years' time. If you look at a divorce, with consent it is 6 months, 6 to 8 months. Without consent, it drags on for 1 decade, 2 decades. There's no real resolution. Suppose the court intervenes, they'll go to High Court. If the High Court is not okay, they'll say double bench. Then they'll ask for review of this judgment. Then they'll go to Supreme Court. So by the time valuable time is actually lost. There's no speedy justice and delivery of judgments here. My current consumer forum case was about valproate-induced pancreatitis. That happened 3 months after starting valproate. The case is going on for 12 years. I finished all our efforts. This is a National Consumer Forum. So my lawyer finished all his argument. They also finished all his argument. When he had to write a judgment, he retired. Okay, so the whole process starts again. So in 12 years, I achieved nothing. So the new judge will rehear the whole case. We don't know when he's going to give a final judgment. So just valproate-induced pancreatitis, OPD care. So it's a 12 years ordeal. He had paid me 8,000 rupees for inpatient care. I must have spent at least 6 to 8 lakh rupees on legal fees and travel to Delhi, staying in hotels all this time. So 8,000 and 8 lakh rupees is no... And nobody is going to touch a National Consumer Forum case to just ask him to listen to my case and give my papers for his review. He will charge you 75,000 to 1 lakh rupees just to look at your case for an opinion. So subsequent appearance, every time he comes, there's a fee for it. Okay, suppose you hire a lawyer from Karnataka, you have to take care of his, airway travels, hotel accommodation, alcohol bills, food, everything. So everything is going to come on you. So it's really not worth it. Not getting into trouble is the most ideal thing. I think just follow whatever Dr. Ravi Stunga is doing is much better, I guess. You don't need legal help, you don't need laws. You must just make sure you don't get into trouble.
I think we have one more session to go. We are already crossed the time. That's why we conclude here. And rest of the discussion, definitely Dr. Mahesh is there in the lunch hour where we can proceed. And I thank the organizers. This is not a usual topic and nobody wants to discuss about these issues. And you selected a correct person and a good topic. And it has given a lot of insight to us. Thank you very much. Thanks for Mahesh also.
I request Dr. Srinivas Bhattyu sir to offer a token of gratitude to Dr. Mahesh Gowda sir. We thank you sir for shedding light on this pressing issue of violence against doctors. This session has provided crucial insights and practical steps, helping us feel more empowered and less overwhelmed. Up next, we have a panel discussion. We would like to set the stage up for the discussion. ಎಲ್ರಿಗೂ ಎಷ್ಟಿದೆ ಎಲ್ಲ
ಮೂರು ಸಾಕು. 3 ಟೇಬಲ್ಗೆ 3 ಸಾಕು.
There's a small announcement. There was a green file folder probably on the third row of this side. If anyone has by mistake picked up that folder, could you please return it? There's a list of doctors that was in it and it belongs to Dr. Satish Rao. So if anyone by mistake has taken a green file folder and if you can find a list in it, please return that folder to sir. Thank you. If you can just open, we have red folders as well. So someone by mistake, if anyone by mistake has taken it, you can swap your folder with sirs.
Hello, attention of everybody. In the meantime, let me invite you, all of you, for evening banquet, which will be in AJ Grants, Kodial Bail. AJ Grants, you're all invited for a small academic session followed by gala dinner. It will be a discussion on small academic discussion on duloxetine. Dr. Arun Bhatt will be speaking and Dr. Ravichandra Karkad will be moderating that. And followed by, we'll be having a unwinding gala dinner. You're all most cordially invited. Please join us. And now the panel discussion will be there. And after that, we'll be having lunch. There won't be any formal validator function because we had inaugural session, we finished everything.
I call upon stage Dr. Madhav Rao to chair the panel discussion involving Dr. Ravish BN sir, Dr. Mahesh Gowda sir, Dr. Keshav Pai sir, and Dr. Samir Kumar Praharaj sir, and Dr. Aruna Yadiyal ma'am. And also stepping on such short notice, Dr. Ganesh Prasad Mudraji sir will be replacing Dr. Supriya Hegde, who couldn't make it because of some commitments. Dr. Madhav Rao sir, he's obtained his MBBS from BMC in January 1976 and is a recipient of Government of India National Merit Scholarship throughout his MBBS. And a post-graduation was completed in neuropsychiatry from NIMHANS in 1980, and he's a fellow of American Psychiatry since Jan 2014, life fellow of Indian Psychiatric Association. He worked as an HOD and senior specialist in psychiatry at District Wenlock Hospital from 1980 to 2001, with concurrent teaching to KMC students during postings. He was deputed by Government of India to Institute of Child Health, London, in 1998, has visited 34 countries so far, and has presented many papers in world conferences. His professional achievements are, he's a recipient of prestigious Dr. LGP Achar Oration Award for Lifetime Work, Community Psychoeducation, and Novel Non-Pharma Therapy Technique in OCD, 2018-2019 conference held at BMC Bangalore. He's an eminent psychiatrist award received for Lifetime Achievement and Service in the Field of Psychiatry in 2021 Mangaluru, Conference Indian Psychiatry Society Karnataka Chapter. He's a founder and past president of MPS since 1982 and President Dakshin Kannada Rationalist Association 1982, promoting scientific temper and psychoeducation to eradicate myths about mental illness, and has conducted more than 550 programs in schools and colleges and villages since 1982. He has explored more than 50 haunted homes or areas, exposing myths about it and spirits and ghosts, educated people by demonstrating hands-on how miracles are performed by tantrics and mantrics and pseudo-gurus through magic tricks. BBC and Discovery Channel have recorded his programs of miracle exposure in Mangalore. National Geography recorded his demonstration of spirit possession and outsting through classical hypnosis in 2005. He has written more than 300 spontaneous poems in Kannada covering various topics like nature, philosophy, love, national integration, published since 1983 in many newspapers, souvenirs, and magazines. Thank you. Over to Dr. Madhav Rao to chair the session.
Thank you very much for the kind words. And to introduce, I don't have the CV of this one, but to introduce them, it is Ravish. It's like taking sugar to Mandya. You already know Aruna doesn't require any introduction in Mangaluru. And Keshav Pai, Professor HOD from KMC. And we have Mahesh, who just spoke to us, and his CV is already known to you. And Samir has come from all the way from Manipal, and with short notice, Ganesh Prasad Mudraje is there. He is important because one or two cases we have jointly done something, and through his help, we could fight a case of blindfold reading. He volunteered, which is not exactly connected with this topic, but he has exposure to legal issues. See, as we all know, the history of this one about law, legality, mental illness is there since limitless time, as old as the human race, Neanderthal or the caveman. But systematic thing occurred nearly about 200 years ago, and about 112 years ago, 1912 was the first Indian lunacy, sorry for the word. What was there, I have to repeat it, act. And then there was the Mental Health Act of 1950, which many may not be available. May not be aware. Then came the 1987 Act, and that became a law in 1993. The 1987 Act itself was good enough, but there was objections that the human right and patient's rights are less in that, and that has to be. Practically, I am practicing since 1980, 44 years, nearing 43 years plus, and we never had any sort of problem the beautiful days of 80s and 90s. Psychiatrist takes this one with passion, and he is like mother, and all the psychiatry patients are his children, and what is best is known will be done by him. That was the concept by at least next of the kin, if not the patient who doesn't have insight. So with that faith, they were coming. And consent to ECT and all was unheard of, though I used to explain what it is. This was the scenario going on. Once there was pager, mobile, internet, then there is a change in, there is a preamble I am giving, scenario, and the Italian pizza is transferred to our plantain leaf. And then I always say, which I told in 2014 also, what they have made, in my opinion, which we'll discuss later, is too much of over this one emphasis and everything copying of the West. A person who did not practice in India, the main person responsible, and it is like now eating ragi ball with knife and fork and chapati with chopsticks. To take a thread from Mahesh, the budget we have is too low, very low, microscopic. Number of clients we have, 1,000 times more than the West, but we want to copy it. So this is the scenario. Now, with the huge number of panelists, each one may get about 8 to 10 minutes time or less. Let's carry on the pros and cons and the merit and demerit of the mental health 2007 MHC care bill. How to start and whom to start, because number is too many. I may have to toss Generally, the panel discussion is 2 or 3. So let me start with person next to me, Ravish. About this one on the mental health care. This one, see, there you.
Okay.
Maybe I'll start with a question. See, there are 10 chapters, right, or 16 chapters, and articles are there, each one. The very preamble of this one is about definition of mental illness, where the perception, delusion, insight, everything is thought, everything is included. But there is no mention of mental subnormality. And why is that, or what's the reason? Which was not there in 1987 also. That has not been addressed even now.
This act is more inclusive with regard to mental illness. Number one. Second thing is, it is primarily focused on protecting the rights of the mentally ill. Third one, with regard to intellectual disability and other things, there is a separate legal enactment, rights of persons with disability. So here, this MHCA focuses on mental health establishments, admission procedures, and the right for mental health services. And while giving the services, no rights violation happens. If it happens, there is a penal clause as well. And formation of statutory bodies, formation of central and state rules. So these are the issues that is dealt by the current MHCA. So clearly there is a difference between when we issue the disability certificate also, mental illness definitely comes as a separate heading compared to the intellectual disability.
Thank you. Thank you for the clarification.
Regarding the inclusion of mental subnormalities in the Mental Health Care Act 2017, I think it is they have missed it. It is the inclusion of people with the mental retardation has been not taken care in Mental Health Care Act 2017. What is your opinion with that? There is exclusion in the. They have not included mental retarded patients. They have taken only people with the mental illness. And another issue is they have not taken care of people with the minor mental illness. When they are giving the definition of psychiatric illness or mental illness, they have taken care of only severe illness. What about the neurotic spectrum of patients?
No, my opinion, no, it is common sense when one has insight. Is it necessary for a relative to, when you approach with anxiety or, some stress-induced burnout? Is it necessary? That's the reason probably, I guess. Regarding the mental retardation, he already clarified, Ganesh, that it's a different, this one, and not illness it is. It comes under disability rule and law. He explained.
Primarily, this focuses on the protection of autonomy of the patient. Number one. Second thing is, see, the classification of minor or major, here, the capacity to consent or the capacity to whether they have to be sectioned as supported admissions. You can't even call involuntary, because I think the chairperson was very categorical that not to use involuntary, because it's only restricted to MHA 1987. So whether it is supported admission or a voluntary admission, that's all.
Okay, thank you for that. Dr. Mahesh, may I ask you about the Chapter 3, Section 5, about the advance directive? A written document should be there and no mention of capacity assessment at the time of making advance directive.
But the patients, patient right groups and the government did not actually initially think that the capacity should be assessed in this sort of scenario. They believe that everybody who is a citizen of this country has the capacity to make their own choices and decisions. So there was no need for separate assessment. They don't want doctors to be involved in legalizing these sort of procedures. But the capacity assessment document includes this at the time of advance directive. So that is there in the document, sir.
Okay. Similarly, in the same line, Dr. Keshapai, this Chapter 3, Section 8, there is advance directive made under Section 6 may be revoked, amended or cancelled by the person who made it at any time. Here again, there is no mention of whether he is capable of cancelling his capacity. This one is not there.
I said that when I reviewed it, lots of literature says relevance of these concepts to Indian scenario, the ability to take advance directives and nominated representative, whether they can do that is itself is a questionable when the patient has mental unsoundness of illness or anything. So the flaws is that they say it cannot be applicable. There could be amendment to that also in future. I'm not very sure, sir. It may not be appropriate in many cases, they say, the application of this.
Yeah.
Maybe minor anxiety or minimal depression where they can have that, say, I don't want to be given ECT, I don't want to be given some injectiles. I think so. I'm not having any experience with that. Maybe the audience has better experience to say their say on this. I have not come across anybody in my practice saying they will go for that.
Dr. Aruna, I am not going to ask you any specific chapter law and all, but in your opinion and experiential this one in the hospital, how many of our masses or the community or the clients or next of the kin are aware of all these things?
It is just like the tiger goes into a forest and there is a board which tells don't kill tigers. Killing tigers is, punishable. So does the tiger know the language in which you have written that to understand that poaching of tigers is illegal? So the same thing is happening with the mental health scenario case, where most of our patients, where they don't even understand the nature of the disease or the treatment that we are giving, you are trying to tell them a rule which actually protects their rights. They don't know that they have rights. So it has become mandatory that all mental health establishments, including Kankanadi, where there is a tertiary level that they put up boards where they tell that you have certain rights and if you're being violated, you can actually complain. These kind of boards are being put. That is the new thing which we have seen after the MHCA has come. And if you have registered yourselves as a mental health establishment, they require you to tell what are the rights of the patient in red boards or blue boards and put them in places where you can actually tell that the patient has these many rights and this. So educated patients can actually read the board and get back telling that why are you keeping me, you're not supposed to keep me more than these many days, we can complain, those kind of things. But what we usually see in a mental health establishment with people of some knowledge of this MHCA Act which has come is if we try to tell them that, yes, there are advanced directives, yes, you have a right to choose treatment, but it will always be we are submitting everything to the board. MHRB board is there. So if they tell that you can't admit me, doctor, why have you kept me here? It's an involuntary this. Then I tell that there is a provision of involuntary admission. I am going by the law itself. I know that there is a law, like just like you are aware, I too am aware. But we are noting down that it is an involuntary admission and we have submitted your documents to the MHRB. So probably if the patients become more aware of these laws, then the remedy for it is the doctors also should become more aware of these laws. So there is a very recent article in the current IJP which has come. Dr. Savita Malhotra is the lead author and Dr. Mahesh Gowda is also one of the authors. It tells that almost 50 to 60% of practicing psychiatrists didn't know about the rules of the MHCA, or they are not aware of what is happening. So they are not aware of the advanced directives, these kind of things. And 92% of those people who have responded, practicing psychiatrists, and most of them are senior psychiatrists who have responded, they have told that it is not implementable. The current MHCA in its current state is not implementable. That is the, the summary of the article which says that with its current provisions it is hugely unimplementable, and it also goes against the spirit of the Act itself. The Act tends to protect people, but it is not doing so. See, even if the patient and patient party is getting some kind of protection, we are for it. But they are not getting that. If you drive a wedge between the patient relatives and the psychiatrist, it is not going to help the cause of the patients either. So in its current state, it is hugely unimplementable. And yes, it is a cut copy paste from the Western setup, and it is being imposed on the setup of India, which many people might have noticed that caregivers are the main stakeholders. So if we try to drive a wedge telling that they have to have a nominated representative, they can't take care of these people, and the state is also not taking responsibility of the patients, I think the patients will tend to lose if the MSCA is brought like what it is written in the paper. If it is implemented, the patients are the biggest losers here. So not just the psychiatrists who are being pointed a finger at. And the worst part is they are making psychiatrists, like practicing psychiatry is looking like something we are doing like an illegal trade. I have questioned myself that why that rule is there for only psychiatry. It has to be there for all the specialities. Why only rights of mentally ill are important. Rights of everybody is important, not just mentally ill. So when it comes to that, when they put on so many rules, it feels as if psychiatrists are paying a penalty for being psychiatrists. So that is not fair on the psychiatrist's part also, because we are also working with the best intention of our patients only. We are not working against them. What MSC is practically doing is putting psychiatrists on one side, putting patients on one side, like they are two opposite parties. We are not on the opposite side. We are on the same side as patients. So that is what MSCA should strive at, is what I feel.
Excellent. I am very glad that I asked right question to the right person. So much of stock was there, which you could express so effortlessly and in an understanding manner. Now, may I request the opinion of Samir, especially in connection with chapter 3 of about the MHRB, this one, and your personal opinion about this whole thing, whether it is too much towards the patient friendly or too much of inclination, 90% that side or 10 this side to the therapist, or it is 70-30 or 50-50. Your opinion, I'm asking.
Thank you, sir. To discuss about MHRB, I think there are some good provisions definitely in the Mental Health Care Act. Many new provisions like what Dr. Ravis was saying, it is basically to protect the rights of the patients, specifically patients who don't have capacity, and that's very important. But if you see in real life, real practice, I think Karnataka would be one state where MHRB and all these things are functioning really well. There are very few states actually in India where MSCA is actually implemented. I think the MHRB which governs us, I think Bangalore, Mysore and even this region, Udupi, Mangalore region, is one of the most active MHRB that we saw. And with that, there are certain good things that happened because they made us actually document things in a very proper way. And we do have to report regarding admissions. So all admissions are now being reported within 7 days. All child admissions, female patients who are admitted are being reported within 3 days. So those things are happening really nice that way. There is a lot of paperwork, I think, practical problems which would arise. So initially, I think most of the centers who have been practicing here have faced that we had to change our documentation process. There are some loop sites also that I wanted to bring to your notice. Specifically, I would discuss in context of, let's say, ECT. Till now, if you see, before MSCA, we had unmodified ECT. We were practicing that one, and it was quite safe and quite effective. We never faced any problems. I myself practiced, I think, unmodified ECT for almost around 10 years without any problem. If you see in MSCA, it was clearly mentioned that unmodified ECT is a treatment which is not to be given. And if you see, it is actually listed along with other prohibited treatments, which includes something like chaining and other form of sterilization. I mean, how do you actually think of unmodified ECT comparable to sterilization procedure? So we never practice sterilization that way. So in a way, actually, the way it is portrayed, the ECT is portrayed in MSCA is pretty bad. Of course, we practice now modified ECT. Almost we are all forced to practice modified ECT. Now, what happens when you get an adolescent patient who requires ECT? So till now, there was no problem. I mean, with MHA, we could easily give ECT to adolescents. Now, anyone who is less than 18 years old, you know, I mean, we cannot give ECT directly. And we have actually faced problems in our setting also. And you know the process now. We'll have to write to MHRB, ask for the permission. And there's a board who decides whether ECT can be given or not to adolescent. We had a situation in which we had a 17.5-year-old patient, not yet 18. So we had to write to MHRB asking for permission. And we could not give ECT immediately because we had to wait till they reply back. We had to try other medications. And finally, they refused actually. They said, you cannot give ECT to this patient. Whosoever was on that board, they said, this is not a fit case for ECT. It's a very strange thing. So the only thing that we could do is continue with medications. Waited 6 months later when patient turned 18. Now we can give ECT. So it's something which is really bad. I think MHRB, the way it is functioning has, I think it is going beyond its mandate. That's what I would say. I don't know about this advanced directives. I don't think I have seen any patient who came with any advanced directive till date. But yes, when there will be more awareness, possibly people will start registering for advanced directives, and we'll have to follow that because we'll have to follow the law of the land. There is no other way out. Now think of a situation which sir was, I think, asking. A person was given an advanced directive that I will not take ECT whenever I fall ill. Let's say I have bipolar disorder. I don't want ECT when I'm in manic state. And you'll have to follow that, whatever that is being written. I mean, whether even if you believe that the person is in a state where you can it can be life-threatening, but he'll have to follow it. I mean, there is no way out. So, as long as the patient again, let's say when he's recovered in remission, again changes his advance directive, we cannot administer that treatment, even if you think that's the best treatment available. So, so MHRB, that's what there are problems, is what I understand. There are many things which are actually brought in the MSCA for good, but the way it is being practiced can be detrimental for the patients also.
Thank you, Praraj. Yeah, surely. I'll just say a few words about what you said. Now this round I'll take this one of minor, ECT for minors, one issue. The adult, this one I want to ask especially three here. The KMC, Mangalore experience, Mahesh, private practice, and Ravish as a professor. That I'll come later. So the most important thing in our field is insight. When we are talking about a person who doesn't have no insight about the depth of depression and, seriously dangerous to himself, and the proof of the pudding, when you look back after therapy, thanking you, or the family appreciating that, you're totally gone and you are brought back, that philosophy and that this one is going away. Just because you make a directive and say that no ECT, you allow him to commit suicide when the ECT melts the disease, like how the heat melts the wax. So this is something I don't understand. And before I forget, there was a very good comment by Aruna. Is it only for psychiatrists, all these restrictions? Why there is no regulatory authority for coronary bypass or stent? Whether it is a stunt of the cardiac unit or the hospital stunt, or is it a really stent is required? Why there is no board which should certify, yes, there is a block and you should go on. So this always, what she said is correct. No other tonsillectomy, none to care. Any other branch, it is not there. Here, you are really so much restricted. Now to the question of ECT in adults. Before that, you wanted to say something. After that, I wish to know, and others also wish to know about ECT in adults in, say, Mysore Medical or government setup, and what are this one in Dr. Mahesh Spandana setup. We'll come to it. ECTs.
No, I just wanted to raise one point. The advance directive are not absolute. So there is a provision that if the treating doctor feels that he has to give ECT, then he has to get a concurrence from the MHRB.
But who is that authority? Is he a psychiatrist or who are there?
MHRB is basically a committee where there will be one psychiatrist, one mental health professional, one representative from the, family of the. So there is a composition.
Senior psychiatrist is there?
Yes. Usually it will be the psychiatrist from the district hospital or the district medical college.
Okay.
But as Samir said, the experience have been a bit cold because, usually treating doctors are given more weightage that they are a panel, they have a department who have come to this conclusion, and then it's more of a formality that it goes to the MHRB. But here, extrajudiciary, more of technical issues were also taken up.
Okay. Shall we discuss a bit about ECT and the new this one, starting from Keshav Pai, and private experience by none other than Mahesh. Then I'll come to Ganesh. See, you're my next neighbor and like younger brother, so don't mistake. Those who have come far off are blessed, with exception to the lady as a gentleman. So otherwise, this one, and next is you. Okay?
Regarding ECT and usage, I would say it has come down in our setup. Not that we cannot give, not we can't have the facility, we have the facility. But the patient selection and preferences are little less these days. And we prefer them giving only for the identified cases where the extreme degree of severity of the illness, immediate care is required, we prefer. And me belonging to both government and private, we have facilities in both the sides. So we don't have any issues. But with regard to Sami's question of giving ECTs for the unmodified, we don't agree, because I'm not sure how much ethically we are able to prove it for a patient, because it's for the safety basically, the anesthesia is required. And I had seen myself giving unmodified ECT in my training in Manipal where I belong to, but of late we have stopped that because I'm not sure how the patient would perceive it without giving any. That's banned. So, but he was saying about it's not it. Yeah, not valid. No. And under 18, yes, that is not, the provision doesn't permit for the children. We don't give ECTs for children because convincing parents also difficult, and maybe lots more litigation later on that you created brain damage and giving an evidence that we didn't create, or the child had come from a difficult labor and hypoxia. It goes beyond our purview to convince them that what I gave was the treatment for them. I never did. For the same reason, I don't take up any probably adolescent trials also for the same reason. There are many trials which do keep coming. In this MSA Act, there is a clause separate permission to be taken from the IEC and others for the clinical trials for the psychiatric patients also. So convincing them is difficult, taking an informed consent and a LR is also difficult. Then convincing the ethical members who are non-psychiatrists also sometimes difficult. They keep on asking, how do you say that patient is not suicidal? How do you say that you have assured that they meet the criteria? So this has been the practice, but I still have a doubt in the corporate sector how the registration happens. I'm not very sure whether they need to be registered like teaching government hospital, medical colleges. Do they need an establishment to have a license? I'm not sure. Maybe I'd like to request Dr. Poonam to comment upon her experience in corporate sector. Do you have the right to admit and give ECTs? But I've seen our colleagues giving very freely. I'm not very sure whether they are aware of mental health care practices required for the corporate sector. Does that come under advanced directive and we can keep on doing that? I'm not sure. These are the gray areas which I'm not very sure, the difficulties. I request Mahesh to answer because he has experience with clinical trials also.
If you look at ECT as a procedure, I think there's certain minimum standards and safeguards that all of us have to take. Unless we are a registered practitioner under the state authority for providing mental health services, unless your organization is registered for MHE services in Karnataka, we must not actually attempt to give ECT is what I'm thinking. You're looking at what the court also looks at is, suppose you give it as an outpatient procedure, you did not have this sort of backup measures to resuscitate somebody who does not recover from anesthesia. All those things become difficult to explain. So it must be done with due precautions and procedures needed to take care of all this sort of complications also. It must be in a good medical setup. And we should not lower our guard that it's an outpatient procedure. There's no mandate that you have to admit this patient and all those things. For the sake of defending legally, minimum norms and expectations that we must keep in mind here. We continue to give ECT, general adults having this sort of indications, whatever is needed, Section 86 versus Section 89, 90, all those things we have still been giving. We've had 3 occasions for giving ECTs to minor after this act was passed, and I had to seek admission. So because I have to seek permission, there's an inherent deterrent. I have to really scrutinize, does this patient really need this ECT? Will I stand the scrutiny of the MHRB is what I keep thinking. The first case I submitted documents, I got the approval, and we gave this patient 6 ECT. Patient did well. He also came to our hospital, interviewed the patient's family, looked at how we do our procedure. The MHRB chairperson and this team was there to look at what we do in our setup. Once he came and saw, after that, his guard about monitoring us and complaining and reporting on our use of ECT would obviously come down is what I suppose. The second case, he did not get back to me at all. Because we wrote up, he has got a procedure, we need 2 certifications, we need forms filled by psychiatrists, medical history, and need for ECT justification. All those things was a document that we had to submit, including medicines that we are using also. These documents would go to the psychiatrist empaneled in the MHRB for opinion. So invariably they are our own colleagues, so they give opinion to say that this can be favorably given. So I did not have a problem in convincing the people in the board also. The second case, they did not get back to me at all. I followed up, no response. The third one, I wanted to send, this MHRB has retired. I don't know to which email I must apply now. So the current situation right now is the district judge in charge in each particular district is made as a chairperson of the MHRB, and we must know who this person is. I don't have the access to know who this person is. I don't know which email to correspond. This is my scenario right now. I've asked people for clarification. Nobody has given me the email ID where I should send. So I'm still sending all the correspondence to earlier email ID, because if I don't make any correspondence, it's my problem. So I'm doing my duty, sending all the required details of admissions, 89, 90, approvals, whatever I have to do in terms of restraints and all those things. I'm sending in the same prescribed pro forma to the earlier mails. So I don't get any response now. For the last 1 month, it's been defunct.
Sir, with adults, we don't have a problem. It is legal, and yes, like MHRB, we document it and send it to the MHRB thing. Not necessary, sir. If it is the clinician's decision, we don't have to take separate this. Only if it is involuntary admission, we have to report to MHRB. That's all. Otherwise, routine ECTs, what we give is not what is something MHCA doesn't object to it actually. And with the reputation of Kankanadi, I don't know. We have patients themselves coming and asking, Satish Rao sir idaga kortidralla madam adondu current kottubidi alla yake tada martiri. So they only tell us that it's been 2 weeks, you have been trying with your medicine, so why not give ECT? This feedback has come from patients itself. So maybe at a tertiary care level center where the reputation of Kankanadi is so good that probably they feel that Shetty doctor kortidru, Satish Rao sir kortidru, iga kodi. So that feedback has come, and yes, it is good enough and effective also. And it also depends on how we put it across to the patients is also what I have found, sir. If we put it like a very scary thing, they current pass marteve, they might step back. But if we tell with all the reassurance that this works and this is quite effective and it is under GA, the patient doesn't feel pain.
No, I am asking in connection with the...
No, sir, MSCA doesn't mandate us to do that. Only if it is an involuntary admission, plus we are giving ECT, we make it a point to tell that we are also giving ECT. So anything we have, if it is an involuntary admission, we have first only put that MHRB capacity assessment, and we have put that we are doing involuntary assessment. The document is there, sir. Some document is there. That is been uploaded. Suppose for that patient we are giving ECT, we also tell the MHRB board that we are doing it.
Okay. Okay. Would you like to add anything?
So with regard to our government setup, actually, what Dr. Samir meant by direct ECT is, it was a partly modified ECT. Like we would give atropine, okay, so that the complications are minimized. So it was actually beneficial and quick, because once...
Only atropine or atropine pentothal?
No, atropine and sometimes lorazepam. Okay. Now, Now what has happened is we have to send them to the OT because the anesthetist can't come. In government setup, there is always human resources problem. So you don't have enough anesthetists to come into psychiatry department and then set up the cartridge, the cart where there is oxygen and then suction machine. So you have to send them to a separate building, and before that you have to have a pre-anesthetic evaluation where they don't want to take any chances. So all the investigations which are not relevant for the psychiatric illness per se are being done. So, and the complications compared, as psychiatrists we know that with partially modified ECT, it was much more beneficial because it's with the experience we are telling, but it's more of a bigger universal human rights activists who are against the ECT treatment per se. Okay, so, but at least we are able to give ECT with general anesthesia. We should be thankful. Otherwise, it has become more of a cumbersome process.
Yes. In fact, in one of the APA conference, there was a huge protest by Scientologists, Tom Cruise and the Thomas Huss group, for the medication itself. There is nothing like child psychiatry, and child should not get even a single tablet till 18, the other extreme. Now, the chapter 12, section 89, there is this one which affects someone like Ganesh Prasad, who is a solo practitioner in Puttur. What do you?
89. Yeah. Admission beyond 30 days. Chapter 12, section 89 says, admission beyond 30 days to be examined by 2 psychiatrists. Sir's main question is what is to be done when there is a private practitioner or private psychiatrist, like in Puttur. Only one psychiatrist is there. So how do you manage? Fortunately, I did not come across any patient whom I am admitting more than 30 days up till now. If the case has to be admitted for more than 30 days, maybe I will be referring to Ravi sir or Madhav sir or medical colleges, many medical colleges here in Mangalore. DMHP. Yeah, but sir, they are coming once in a week. I can't, they have their own responsibility. I can't take the help of DMHP people. So this National Mental Health Policy says, has given many rights to the patients. So my question is, there is a right for a psychiatrist also. See here, imagine a hypothetical situation. I have to, it says where a psychiatrist needs to admit a patient or give mental health care only in registered hospitals. See, in Puttur, the reality is Puttur City Hospital is the only hospital which has been got registered. So I being the only psychiatrist, there are 7 to 8 private hospitals. Many times there will be a consultation liaison psychiatry. I have to go to various hospitals. They have not been registered. So in that scenario, what I should do? Whether I should keep on educating them about Mental Health Care Act 2017, I can't come to your hospital. I can't see the patients who are suicidal. Many times they call us. So many times I need to see patients. So what the people like me have to do? That's a big question. I think, see, to give you the figures, government has provided only 68 to 70,000 beds in India for mental health care. So remaining, if you take the statistics, there will be about 10 to 13 crores of mentally ill patients in India, if you take the population into account. So, the government is catering and giving services and giving the beds only for 68,000 people, 68,000 beds, and remaining whole care has been given. Almost 90% of the care is being given by people like me and you, and they are troubling us with this kind of loss. I am seriously opposed to this kind of licensing Raj kind of things. I think it is not good. See, it will impinge on the rights of the patients also. See, if I can't go to many hospitals in Puttur, just by saying that I can't come, so those patients, what the patient has to do in those hospitals? So, I don't know. This is a big question.
Thank you very much. That was the next question by me, what was supposed to be. Either you read my mind or read the notes. That was the next question. What I wanted to ask you, which you have covered. Now, continuing the thread, I have a very important question to all the panelists. See, there are general hospitals where a severe alcohol, this one with compromised liver function, fever, superadded malaria, dengue, whatever is admitted. Or there is a case of an elderly where there is puking, vomiting, summer, and hyponatremia. Or there is a case, patient admitted with fever, headache, vomiting, and turns out to be meningitis. In all these three scenarios, organic or metabolic or toxic, there develops a behavior problem, confusion, and it goes beyond 72 hours. And the general hospital is not registered, as my younger brother said. So what should be done is my genuine question to all the panelists. Please enlighten.
Sir, in our medical college, I will tell you what happens. The MS has directed us regarding some guidelines in these scenarios, because this cross-referencing is very common, because other wards might have the same scenario as you told, behavior disturbance and all. So what they are trying to tell is, if you can't work with the rules, work around it. That is what the MS has told, and he is telling it is legally possible if it is still admitted under a physician and it is given as a reference to a psychiatrist, the psychiatrist can go and see, even if it is not a mental health establishment.
No, this one, Aruna, yours is an institution which is registered, and in that compound, there are departments and there is liaison. My specific, this one is about so many general nursing homes. In Puttur, there are 6-7 years to attend, only one is registered. And sometimes I am also called, I don't want to name the nursing homes. So there are these problems, and sometimes the behavior change, confusion, or bit violence and vivid hallucination goes beyond 3 days. Here I have a question, what to do.
I will tell you what, I don't know whether it is what MSCH says or not, I don't know, sir. But what is legally done here in Mangalore is, all the private psychiatrists also, they go and see their patients. But if it is not a MHE, that is mental health, if they are not treating the patient in a mental health establishment, they see to it that the patient is admitted under a physician, orthopedician, or somebody, the name is admitted under somebody, but you are treating the patient as a reference. Like they make you give a reference to a psychiatrist and the psychiatrist is treating.
No,
that is how they do it. Or the owner of the hospital, it is admitted under the owner of the hospital, bar doctor, and that is how they are treating it, sir. And our MS has told that it is legal, so you proceed with treating them. That is how he has put it to us.
See, there is a punitive, I think you are aware of the punitive clauses in the Mental Health Care Act. If you go and treat a patient in a unregistered hospital, you are liable to be punished with 25,000 rupees. This is ridiculous for a psychiatrist.
Even for referrals, sir?
Yeah, you can't. We are taking the risk. People like me in Puttur, we are taking the risk.
No, that's the very reason I am bringing this practical issue. the next thing before you wind up would be, can anything be done or it is too late? There is a provision in section 125 or 126. That will be the last question. Now I want a clear opinion of Ravish and Mahesh about this. They can only tell us.
The best thing is to ask the other 6-7 hospitals to take the license.
5,000.
Yeah, but see, finally the charges will go to the patient. So I think bypassing is not allowed, legally speaking. So you have to either ask those hospitals to take license or else shift the patient to your mental health establishment where they should have a physician and a ICU setup as well.
I think in ideal scenario, what you are telling is right, sir. But see, to convince a hospital owner to get a registration, every year they have to renew, every year they have to pay 5,000. See, when they will get once in blue moon, our patients.
The MHRB, the words which I would get from MHRB chairman, even at 9:30 while having dinner, ignorance of law is not pardonable. It was direct.
That is true, but it is not fair in a metabolic, infective, or alcohol withdrawal state. These are the sub-modifications that should come. In the event of any acute organic brain syndromes, even if such patient is in any private hospital which is not registered, therapy there by a psychiatrist is okay. This is sensible. It has to come. My opinion. As they have opinion sitting there, a fellow comes from UK and they don't ask Ravish or Mahesh or me or anybody, and they form a 2017 this one when our Indian Psychiatry Society, what it was doing. I hope none of you are members, secretaries or presidents, those dates. Okay. Then maybe I was there, Karnataka State, 2014, but my words, I was helpless. Mahesh, can you enlighten about this?
So here I'm looking at two scenarios where I really want the patient's outcome. So that's the first head. Second one, what is legally correct. So if I look at what is the patient needs, he needs to be treated. So whether it's in a private medical establishment, you're using the 3 days window and say this is the emergency treatment and managing. But the law makes it very clear the patient is being treated with his threshold of illness. The illness has been defined, his capacity has been quantified, you know what exactly to do. He's incapacitous patient, he has severe mental illness. Nobody else other than a psychiatrist has any business to treat this patient. It has to be under a mental health establishment according to the law. This is how the MHRB is going to interpret it. It's not me interpreting. We've had enough discussions with him. He says, this is the law. I don't care what you think. I don't care what the patient is going through, but this is the law. Severe mental illness, capacity is not there. It must be sectioning 89 after 3 days, and he must be in a registered mental health establishment. Suppose you offer services. Penalty clause is what he is talking about. Definitely very important. Knowing fully well is not registered if you're offering services, you will be penalized. So how to circumvent this sort of scenario? So suppose you get this sort of reference, you can go see them in ICU first time and say that this is your evaluation, you say delirium, query, cause, all those things, and say patient has been advised to be admitted under mental health establishment under psychiatrist in view of these sort of provisions. You can write it down. You've done your justice, you take your consultation fee and be done with it. Don't see the patient second time as an inpatient because you already mentioned he has been mental health establishment. Suppose there's still a need that he has to be evaluated. Ask the department to give an OPD reference letter. You see in your OPD department because OPD patients don't come under purview of this thing. You claim ignorance that you never knew that he was admitted. So give your opinion on OPD slips. This is the only way to circumvent it. What is good for the patient may not be legally correct here. So if I'm a psychiatrist running a specialty center with so many psychiatrists doing sectioning and doing all this sort of work, I think this is a specialty by itself. You have to be trained and say that this is a specialty which none of the other people should attempt. DMHP psychiatrists, there are resource constraints. They don't have the option of a second opinion. They should not admit anybody for sectioning and treat them. refer them to departments. There are so many medical colleges, they have required infrastructure, please refer them. It may be cumbersome for a patient to go there, but I think you're helpless. If you go back to my previous talk, please don't venture into what you are not capable of handling. You cannot handle sectioning alone. 89, 90 both need a team of people to do it. Single unit psychiatrist should not really venture into it. It should be a system. It is going to be a specialty in the coming days that there will be forensic psychiatrists, there's going to be sectioning doctors who are going to take care of only certification, assessment, sectioning under 89, 90. I think it's a subspecialty that's going to grow. Let's respect it. Patient need this sort of scrutiny. Law enforces this sort of scrutiny. MHRB, which is going to be punitive on us, will expect this sort of minimum standards of care for patients. So there's no way you can surpass this.
Okay, thank you very much. Let's keep time also in mind. It's 2:30, so we can go on theoretically on and on another half an hour. But what's the final practical implementation, or will there be of any use? That let's come. Now it's the last, this one. Any one of the panelists would like to add anything? Keshav Pai, Mahesh, Aruna, Ravish? Anything you want to add to this? What has been missed by me or oversight?
All of us have to be legally minded, keep all this provision in mind. But if you look at the implementation hurdles that we have, we need effective MHRBs for implementation. So what the government of Karnataka has done now is they've removed the, what you call dedicated full-time judge as a chairperson of MHRB for cost-cutting reasons. And they've empowered district magistrates to be in charge as chairperson. So it's an additional charge. They're not exclusively dealing with MHRB portfolio. So now the monitoring, the guard that we have can be actually reduced because there's no system to really scrutinize admission, discharge procedures, all those things. Whatever we are doing, we must be trained to do it. But the sort of scrutiny and monitoring will actually come down because it's going to be somebody who does not know about this act and he does not really have the time to do all these things. Only if there's a complaint, all these things will definitely impact us. So we must follow all the regulations that's needed, and the threat, that fear, that whatever we had seems to be for some time postponed now in the current scenario.
Okay, Ravish, anything?
Now, in the interest of psychiatrists, all I have to tell is we have to be bothered about the licensing procedure. Number one. Second thing is, even outpatients also, it may not require MHCA licensing, but still you are supervised by MHCA. Okay, being a psychiatrist, it will hold good. Number three, 2 carry-home messages I would like to give. So you are in MHG, and then you are a valid, trained, certified psychiatrist. One is always act in the best interest of the patient. Like what Mahesh said, go once, write that suggestion. So like that, always document that you have acted in the best interest of the patient. Second thing is least restrictive procedure. Okay. So if even chemical restraints also will be questioned. So if you can justify that by documentation, there is a hope that since it's been now divided to district wise, not the region wise. So our Mysore region includes Mysore, Mangalore, Udupi, Chikmagalur, and added to that Bangalore also. So Puttur? Yeah, Puttur also comes there. I was surprised that MHRB chairperson has not noted Ganesh. Okay, that's quite surprising. We are all, I mean, he had more eye on the government psychiatrists, and then we were targeted quite often. So now it's limiting to the districts. So, and it will be either professor and head of the district government medical college or district hospital psychiatrist who will become the member in the MHRB. So invariably the rapport with them will help in, because it's a sitting judge. So he will obviously ask, I'm just giving a hope that things will definitely modify. What was like a threat, what was not expected happened with the current MHRB. Okay, even institutes like Niman's got notices and things like that, but it also in a way made things to fall in line. Okay, let us also accept that. So very soon every district, maybe Sunil will be in the MHRB, team. So have good rapport with Sunil,
with him.
and then your whatever request to MHRB will be quickly accepted. And
My humble submission is please don't instigate this MHRB chairman. This Ganesh is going and seeing the patients in unregistered.
There is one.
No, he's retired. Don't.
He retired on August 15th. Yeah. Okay. Now, Samir, you wanted to say something? No. Sure? A minute? Let it be complete.
I think I'll just reiterate what Dr. Mahesh and Dr. Ravis has been saying. If you have to choose between what is good for the patient, ethics and law, first follow law, then you think about the patient. So documentation is important. You at least what is required, if you follow that, document it, then you can do what is the best for the patient, possibly will avoid getting into problems. There's nothing to be afraid of regarding the law that way. If you're sticking to so anything which you are not supposed to do, don't do. That's it. So like treating in a place which is not registered, don't do it. You just refuse. Say that I cannot do there. So so that way. I mean, if you just follow the practices, whatever has been written. Even I think there is another thing we didn't discuss about is restraint. I think each and every restraint that is being done in the hospital has to be reported to MHRB. They make it mandatory. Monthly report. I mean, all the restraints that you have done, and you know how many patients we restrain. So, and how many are actually documented. How many patients we actually document restraint. In ICUs, if you see, 50% or more of your patients will be restrained. Is it being documented? No.
No, even non-psychiatry, this one requires restraint in the ICU.
Also, yes. So there are stringent, possibly like what Dr. Mahesh was saying, in time to come. So inpatient psychiatry will be done by very few people who will be specializing in how to respond to these legal challenges. So you would be sectioning under different sections. You'll be admitting patients, and then all this documentation regarding restraint. It's possibly what is happening now in UK. There's a lot of documentation that happens. Possibly we are not even doing little bit of it the way it is being done there. In time to come, that would be one of the answers possibly. It will involve a lot of paperwork, but it will actually save us from all the hassles.
Okay.
Yeah.
Thank you very much. With the consent and consensus of the panelists and the listeners, I wish to conclude under two headings. Number one, Kashmir to Kanyakumari, Gujarat to Kolkata, there are thousands and thousands and thousands of rules, acts and bills. It is all there in the Gazette and everything is there, but rarely something comes to the surface and it troubles anybody, be it road traffic or no-way, one-way signal or environmental pollution, whatever you can think of. It's all there, but how much it is implemented. But to be on the safer side, as all of them nicely said, one, your conscience, second, your documentation. Why it is done, how aggressive or how unruly, and why CERNET had to be given. A line of documentation would go a very long way, because I have made about 150 court appearances between 1981 to 2002. So with that, this one, everywhere they asked documentation. Once it happened, which let me confess, I had left the identification mark, which was very important. in a 302 case, and I entered the identification mark somewhere in the armpit there, and the pen was different. So judge asked, there is a change in ink. Then I said, sir, I carry generally 3-4 pens, and in an emergency I might have done. Ever since, I am keeping it the same. So with that, he really said, oh, maybe in the emergency room the pen has changed. The second thing which I want to tell is, there is a provision in chapter 16, 125, rule 125. If there is problem, we can, since it has already gone through the parliament and bill and an act and a rule, now under the clause 125 there is a provision by maybe IPS or this one, all these difficulties like what mentioned by Ganesh Prasad especially, if such thing can be put, can there be modification?
No act, yes sir. When, as a lawyer I am telling, whenever any new act is framed, every act will give a remedy. With even constitution has constitutional remedies. So without those remedial clause, it doesn't become a complete act. So there are litigations from Indian Psychiatry Society with regard to these difficulties, which is still going on. So we may see some amendments and things which are not easily implementable. The changes will happen by the law review commission. The feedback that goes, like when the MHRB, which is given a statutory position, so the MHRB can also give, not just the psychiatrist, can give the revisions which will be taken up, and then amendments will happen. So amendment is a legal process. Law is not a static one. It's a dynamic process.
Thank you very much for the input. In fact, the retiring judge who retired on August 15th, he had sent a message on August 1st or 2nd to Father Muller Hospital, and accordingly we circulated in the MPS consultants group, and some of the points we listed, and we have mailed it on 12th or 11th or 12th August. Same way, your words are really encouraging, and the real difficulties can be placed 2 + 2, 4. And if the larger bench or larger group of psychiatrists feel the same way, so naturally one is inclined to change to an acceptable level. So with this concluding note, I will close the panel discussion and hand it over to the ever dynamic Neil.
I would like to request Dr. Satish Rao sir, Professor and Unit Head, Department of Psychiatry, K.S. Hegde Medical Academy, to present a token of gratitude to Dr. Madhav Rao sir. Our panelists skillfully steered by Dr. Madhav Rao sir, shared their personal views and experiences on Mental Health Care Act 2017, offering not only a deeper understanding of its challenges, but also sparking fresh ideas and possibilities for the future. We deeply appreciate their valuable insights, which have truly enriched this conference and will undoubtedly influence our practice moving forward. With that, we would like to conclude today's CME. I request everyone to collect their certificates on their way out, and also thank you for all your participation and contributions. And we hope to see you at night for the academic session and gala dinner at AJ Grand at 8 p.m. Now I'd like to invite Dr. Neelabhami Shenoy
Okay, no, I'm not going to take an invitation, but thank you all once again. I just want to thank all the speakers for this CME, that is Dr. Suresh Badamat, Dr. Ravish BN, and Dr. Mahesh Gowda, and all our panelists as well for today for agreeing to come on short notice and putting together a brilliant show. I speak for everyone when I say that this was probably one of the most enriching academic sessions we've had, and I think it included a lot of real-world pragmatic scenarios. So with no further ado, everyone please proceed for lunch, and we hope to catch up with everyone again tonight at the gala banquet at AJ Grand. There'll be a small discussion on duloxetine just before that. Thank you once again to all the support staff, especially the postgraduates. Without you, we couldn't have made this happen. To all my colleagues in the department, Dr. Madhavi, Dr. Ashwini, Vidyashri, and to the chairperson, Dr. Ravish Tunga, and the co-chairperson, Dr. Kiran Kumar. I am not going to thank everyone again since Kiran sir has already finished thanking everyone. Yeah, we call it a day. No one's listening also.
I'm really overwhelmed the way our whole department responded and took this CME to a highest level. And thanks goes to everyone, each and everyone leading from the front, Neela, Madhavi, Ashwini, Vidya, everyone. And Sandesh did a wonderful job of MC. Thank you very much. Thank you. The whole team, thank you. And let us all,
Live streaming. One line about Namana channel, there's already fantastic feedback about the quality of the online streaming. So thank you, Dr. Ashwini, for recommending them. Thank you.